Pin video na? Huh? இது அன்மியூட் பண்ணனும்ல அது மியூட்ல இல்ல மியூட்ல தான் இருக்கு
Good morning, Dr. Vijayalakshmi. Dr. Dasagar here.
Hello, good morning, everybody. Hi. Hi, sir. Good morning, Dr. Nanda.
Good morning, everybody.
Good morning,
On
sir.
behalf of the organizing committee, I welcome you for the 12th International Eco Course and Workshop, which happens to be a web meeting this year. The program is organized by ISCD and CC and co-sponsored by International Society of Medical Ultrasound. Dr. Navin C Nanda is our course director, father of modern echocardiography and a world-renowned echocardiographer. He is regularly conducting this workshop as a course director for last 12 years. The magic of echocardiography continues unabated. Echocardiography reigns supreme and no other investigative modality really seems to compete with in future. Interestingly, besides its use in clinical practice, ultrasound is now being utilized for therapeutic applications also, like sonothrombolysis in patients with pulmonary embolism, extracorporeal shock therapy for calcified lesions for debulking, and is also being evaluated for gene therapy. Besides Dr. Navin C Nanda, we have a galaxy of experienced echocardiographers of national and international repute. Dr. Vijayalakshmi from Bengaluru, Dr. Rakesh Gupta from Delhi, Dr. Sanjay Mittal from Gurugram, Dr. Manish Bansal from Gurugram, and Dr. Santanu Sengupta from Nagpur. The first session is a panel discussion on current issues in echocardiography. And our esteemed panelists are Dr. Navin C Nanda, Dr. Vijayalakshmi, Dr. Rakesh Gupta, Dr. Sanjay Mittal, Dr. Manish Bansal, and Dr. Santanu Sengupta. Dr. Nanda, cardiologists have been using echocardiography for several decades, but now lung ultrasound is also being utilized in the intensive care, but mostly we said this is being done by the critical care physicians. In United States, how often this is done by the cardiologists and what additional information it provides in the management of sick patients? Dr. Nanda, please.
Yeah, well, it hasn't taken over in the United States very much because here mostly the technologists do the, do echocardiography, and so therefore take some learning curve. But I think there is a very growing interest in doing it because when you do an echocardiogram, the lung is right there, and all you have to do is to actually take your probe, and you can take the same probe that you are doing the echocardiography, and you can put the same and look at the lung ultrasound. So that's very, very easy to do. The learning curve is actually very short, and it doesn't take really very much time to learn it. So that is something everyone should be actually be doing it. Anyone who is doing an echocardiogram should actually also do lung ultrasound.
Dr. Nanda, here was a barrier to the use of ultrasounds. So how do you do lung ultrasound bypassing this barrier?
Yeah, well, the barrier is simply because, the lung, there is a large acoustic impedance difference between the heart and the lung. So generally, you would get nothing there. You would simply get horizontal curved lines, and those are the artifacts. But then when there is water in the lungs, for example, when there is pulmonary edema, maybe left heart failure or some interstitial syndrome, lung interstitial syndrome, then you get water there, and the water actually interaction of ultrasound and water in the lung produce a different type of artifacts. And those are like common type of artifacts, which actually would be in my talk also. And so therefore, you can really make a diagnosis of a lung ultrasound. Also, if there is peripheral consolidation, obviously that is that be permeable to ultrasound, and you can see that lung consolidation very well. Just like you see liver, you can look at liver and then you can see something similar in the lung, and you can see that. So peripheral consolidation you can see very well. Also pleural thickening, because the first thing that the ultrasound hits is the pleura, and you can look at the pleura, which is very thin, and the pleura is thickened and irregular, then obviously it is abnormal, and that is one of the abnormalities you see with the COVID-19, pleural thickening and irregular pleura. Also, you can diagnose pneumothorax, which you can miss on the chest X-ray, and that is done by actually M mode. It's very interesting. It's done by M mode, lung ultrasound M mode, and you get actually like a beach sign on the M mode when there is no pneumothorax, and the lung actually, you can see the lung sliding as the patient is breathing in and out. But when there is pneumothorax, that sliding disappears, and instead of looking at the beach sign, you get a stratospheric sign. So it's very easy actually to do the lung ultrasound, and you can divide actually depending on the mid-clavicular line, anterior clavicular line, and the posterior clavicular line. While the patient is supine, you can do this. So the patient doesn't have to sit up actually. You can do that supine position like someone who is on ventilation. You can do that very easily. If you want to look at pleural effusion, you can do it also the same way, but many times we do it when the patient is sitting up, and that way we can actually find the place where you can actually drain the pleural fluid without causing any injuries to surrounding structures.
Dr. Mittal, we have been using ejection fraction for several years, but now we know GLS is a better index of assessment of systolic dysfunction. It picks up even subclinical LV dysfunction. So has time come to say bye-bye to ejection fraction, or both these modalities are complementary to each other?
It's a wonderful question. The answer to the first question, whether it's time to say bye-bye, I don't think it is, because all the guidelines for heart failure treatment today are based on the number ejection fraction, whether it is ICD indication or whether it is CRTD indication, or for that matter, pharmacological management. We know there's still no major treatment for heart failure with preserved ejection fraction. We are still groping in the dark to identify that disease. The value of GLS is definitely going to be there. Probably we'll have to require much more bigger studies in the population to get the guidelines there. However, it is more of utility for heart failure with preserved ejection fraction, because it can pick up the earliest detection of LV systolic dysfunction, which may not be evident by just ejection fraction number. So that is something which is there. So the answer to the second part is yes, they are complementary and they should be used judiciously in the proper clinical scenario, and it would be the best yield.
Dr. Rakesh Gupta, GLS is routinely used in patients of cardio-oncology to monitor cytotoxic therapy. It's also used in valvular heart disease, also used in coronary artery disease. What is preventing it to come in the guidelines?
It will take some time. All these factors of strain imaging, obviously, once they are incorporated into clinical practice, and couple of trials which are required to do all these kind of things, certainly they'll be in a guidelines. Last guidelines were written in 2014, followed by European Society of Cardiology in 2017. I'm sure the time has come when it will be incorporated into the guidelines in 2020 or 2021.
Dr. Manish Bansal, currently we classify heart failure on the basis of ejection fraction into half mid-range ejection fraction. But all of us know even the subset of heart failure with preserved ejection fraction, 25% have reduced GLS. So don't you think time has come to reclassify heart failure in a better way by utilizing GLS?
As Dr. Mittal also answered, we have got a lot of data with LVEF. LVEF is much easier to measure. Everyone is familiar with it. So the guideline based on LVEF is going to remain there. But at the same time, as you mentioned, in patients who have preserved EF, they are the ones who have subclinical LV systolic dysfunction, which GLS is able to detect, diagnose, and get prognostic information also about it. So in those patients, we need to do routinely GLS, and those who have reduced GLS within the category of heart failure with preserved EF, in them there is data which shows that ARNI helps, beta blockers help, although in the overall population of HFpEF, these therapies have not shown benefit. But within HFpEF, those who have reduced GLS, we can use that GLS information for treating these patients and prognostication. There are studies which have also shown that if we categorize patients according to GLS, regardless of EF, we can better predict their prognosis, because both HFpEF and HFrEF, they have almost same mortality, 5-year mortality. But if we classify them according to GLS, there's clear separation in the different categories of GLS in terms of long-term mortality. But for the reason I mentioned in the beginning, EF-based classification is going to remain there for all the reasons that we know. GLS will add a lot of value in HFpEF category.
Dr. Sengupta, what is the role of GLS in valvular heart disease?
I think all the previous guidelines till now were not incorporating the use of GLS in the valves, but I think the recent data, a lot of things have shown that, and I'm going to speaking on AR and MR, that there is some role on identifying the subclinical LV problem, and I think strain analysis is going to be very much incremental, and a lot of studies have now shown that if you can pick up this subclinical LV dysfunction in AR, MR, also in mitral stenosis, then you can have a better prognosis over a period of time. Yes, it is going to be, it is very much important.
Dr. Vijayalakshmi, all of us know ECO has been a boon to pediatric cardiologists, but what are the subset of patients where you adopt a multimodality imaging, and what additional information is obtained by it? You are muted, Dr. Vijayalakshmi. Dr. Vijayalakshmi, you are muted. Please unmute. Dr. Vijayalakshmi, you are not audible. Dr. Vijayalakshmi, please unmute. Dr. Chandrasekhar, please unmute with Dr. Vijayalakshmi. Dr. Chandrasekhar?
Actually, Dr. Vijayalakshmi is unmuted, but her audio system is possibly not working.
Okay. Achha. Okay. Dr. Nanda, what are subsets of patients where 3D echocardiography has changed the outcome of patients? What are subsets of patients where utilizing 3D echocardiography has changed the outcome of these patients and provided better results?
Well, 3D echocardiography actually supplements 2D echocardiography in many instances. For example, even in mitral stenosis, one can actually visualize the valve very well. Can look at the subvalvular apparatus for calcification, look at the commissures, and get a very good idea whether the patient will be a good candidate for valvotomy. So from that point of view, I think echo is very good, just in valvular heart disease. I think even aortic stenosis, if you do a 3D echocardiogram, one may in many cases look at the valve area, aortic valve area, planimeterize it. And the reason it's better than 2D is because you can go in and out and examine the valve much better than you can with 2D echocardiography. And of course, when it comes to regurgitant lesions, obviously, we many times on 2D echo, we look at the vena contracta by looking at the length of the vena contracta. But here, really speaking, the vena contracta has its finite shape. So one can look at the area of the vena contracta, and from that, one can calculate the regurgitant volume using the usual Doppler method. So just valvular heart disease is very important. Also, I think when it comes to cardiac masses, what 3D echocardiography does is it sections a mass, and you can look at the structure of what is going on. For example, you may have a clot and it may look like it's completely solid, but when you section it, you can see that there's a big area of lysis. So you can get a very good idea that the clot is on the way of getting dissolved. And even on the 2D echocardiography, it looks like it's very large and there is no lysis. So like, for example, if you have a vascular lesion, you can see multiple spaces all over the tumor. If there's a myxoma, one can actually see some areas of hemorrhage, which may look like a clot lysis, but also you have calcification there because myxomas are very slow growing. And if there's a clot, you're going to have low cardiac output. So these are just one or two examples where I can think in terms of 3D echocardiography actually helping, helping. In congenital heart disease, of course, very interesting, important, because you can view the atrial septal defects as well as the ventricular septal defects en face. And because you can view that en face, you can get the sizes much more accurately, and you can try to decide what type of device or what size of device which will close the defect without actually encroaching on surrounding structures. For example, in atrial septal defect, one wants to make sure that it doesn't encroach on the aortic root or any other structure, or superior vena cava or inferior vena cava. You can do that. Just to give you a few examples where 3D echocardiography can be very useful. But of course, if actually the resolution of 3D echocardiography would have been very similar to 2D echocardiography, which is not now, it's lower than 2D echocardiography, depends on 2D echocardiography. But if it were similar, then actually we'll be doing more 3D echocardiography and very less 2D echocardiography. Just like we are doing more 2D echocardiography and very less M-mode, we're doing the same thing with 3D echocardiography, more 3D echocardiography and very less 2D. But the resolution is still not as good as 2D echocardiography. Therefore, it acts as a supplement to 2D-dimensional echocardiography in most instances.
Thank you. Dr. Mittal, when do you adopt multimodality imaging in valvular heart disease? Dr. Mittal, you are muted. You are muted.
Sir, you are muted.
Is it okay now? Yeah, sorry. Okay now? Yeah, sorry.
Yes, sir, it's good.
So, I mean, we are doing interventional. I think somebody is echoing. What is important? Whenever we are doing multimodality imaging, it's important. Without multimodality imaging, interventions are not possible. If you're talking about TAVI, if you're talking about mitral clips, or if you're talking about the closure of defects and all, without multimodality imaging, it's not possible, because it's a supplemental echocardiographic imaging with the interventional imaging, which is important. So that is something which I would like to say, no intervention on the valvular disease is possible without multimodality imaging.
Dr. Rakesh Gupta, multivalvular lesions are very common in our country. So what tips would you like to give for correct assessment and severity of individual valvular lesion in a patient with multivalvular lesions?
Obviously, it depends from lesion to lesion. Suppose it's a mitral stenosis, we need to have a planimetry of a mitral valve area, and most precisely, as Dr. Nanda said, 3 will lead to a good planimetry area. As far as aortic stenosis is also concerned, we have that aortic valve area by quantitative equation, and we can go to 3 dimensions echocardiography to look for a planimetry. That's for both. On the other hand, if we are looking for mitral regurgitation and aortic regurgitations, obviously these aortic and mitral regurgitation, they have the 3 dimensions planimetry of vena contracta today, where we can really look how much the regurgitant area is. Second, we can look at an effective regurgitant orifice area in these 2 subsequent conditions. The role of a strain imaging in assessing subclinical LV dysfunction, as I'll be talking on AR, is very much useful as on today, along with exercise. The role of exercise in especially the aortic regurgitation will help us in coming to a conclusion when to intervene in these kind of
Dr. Manish Bansal, what is the utility of myocardial contrast echo in the current scenario?
There a lot of studies have been done using myocardial contrast echo in various settings, but myocardial, we've been using contrast for LV opacification routinely, not in our country, but in the Western countries where contrast is routinely available. But we've not been using myocardial contrast echo that routinely because despite all these studies, the incremental value shown in individual patients has been rather limited. So main application has been there in stress echocardiography, in acute myocardial infarction, in some LV masses where we can differentiate thrombus from some tumors and some other masses. And more recently, myocardial contrast echo has also been used for therapeutic purposes. In patients presenting with acute MI, we give contrast and then we use ultrasound beam to cause lysis of the thrombus in the infarcted, in the culprit vessel. But as I said, incremental value and the ease of application have been the main challenges because of which it's not been used that routinely.
Dr. Sengupta, is there a single test for confirmation of diagnosis of HFpEF?
Is there a single test for diagnosis of HFpEF? The answer is no.
Yeah.
I think HFpEF, we are still trying to understand the phenotypes, and a lot of reports have now shown that there are three major phenotypes. We do use echo, we do use cardiac biomarkers, and patient pathology. I think the HFpEF arena is evolving a lot, and there are a lot of studies going on to understand and to come to a conclusion whether there are any therapeutic roles. So I think if the patient is symptomatic, then echo is helpful, and it can be supplemented or complemented by doing a cardiac biomarker. But we need a lot of information, and a good clinical judgment is needed. There are always a role of exercise also in this group of patients who may not have classical echo parameters. So if you exercise, then you can unravel the
Yeah. Dr. Vijayalakshmi audio is not working. Okay, so just see whether there are any questions. Dr. Vijayalakshmi, not working. Dr. Chandrasekhar, please see if there are any questions in the chat box because we have only 4 minutes left. Okay, please post the questions. No, I'm not able to see the screen. Just a minute. Chat box. No. Okay. Again check. Don't ask Vijayalakshmi her audio. Other questions you say. You can ask question to the other speakers because her audio is not working. Another question is, what is the value of evaluation of epicardial fat by echo in assessing cardiometabolic health? Dr. Nanda, the role of echo in assessment of epicardial fat for cardiometabolic health.
In cardiometabolic, I think again, there's quite a bit of role there. Basically, you're looking at subclinical atherosclerosis, and actually look at the carotid vessels and look at the and try to see where there is a plaque or how big the plaque is, what is the character of the plaque, is it calcified or not calcified. One can also look at the pulse velocity, and that also gives an idea of subclinical atherosclerosis. Another thing, of course, is to look at the epicardial fat pad, and one can look at, sometimes you can't differentiate epicardial fat pad from paracardiac fat pad. So you can actually look at the total paracardiac fat pad. Of course, in some instances, you can differentiate the two, and that is also very useful. So there are many, and also one can look at the endothelial function using the brachial artery method, and that also can give an idea of subclinical atherosclerosis. I think out of all these methods, the one which is actually used most often, and clinically we don't use that much of pulse velocity, even endothelial function is not really done that much. But I think the carotids are very, very important, because we know that if there is carotid atherosclerosis generalized process, and if there is atherosclerosis in the carotid arteries, one can get actually an idea whether there will be any calcification or atherosclerosis in other parts of the body, including the coronary arteries. So that becomes something very, very important to look at the carotids patients.
The last question to Dr. Rakesh Gupta. Echocardiography has limitations in detecting You can read it out. You can read out.
I can answer that question if you want me to, Dr. Manoria.
Yes.
Yeah, well, actually, there is something like a subtraction technique which has been developed and actually comes back. And what it does, it subtracts all the echoes which are not very bright. As you know, fibrosis produces very bright echoes. So it takes off all the, of course, you don't take into account the acoustic impedance between the heart and the lung. But apart from that, the subtraction echocardiography works very well. It takes out the regular unechogenic echoes and leaves only the echogenic echoes, which actually correlate very well with fibrosis.
With this, we finish our panel discussion, and the next session is on usefulness of echocardiography and lung ultrasound findings in COVID-19. And the speaker for this session is Dr. Navin C Nanda. Dr. Navin C Nanda, as all of you know, is a distinguished professor of medicine and cardiovascular diseases at the University of Alabama, Birmingham. He is hailed as father of echocardiography, father of modern echocardiography by many prestigious organizations and societies because of pioneering work in adult and pediatric and fetal and peripheral ultrasound. Echocardiography labs and institution have been named after him, and he is the founding and the current president of the International Society of Cardiovascular Ultrasound. He has a masterly approach of slowly unmasking the depth of the problem, and I'm sure you will enjoy the flashes of victory during his discourse. The chairpersons for this session are This session are Dr. Amrish Agrawal from UAE and Dr. Ved Prakash Pandey from Indore. Just show the CV of both the chairpersons. Dr. Amrish Agrawal has been
It's really, as always, a pleasure to be with Dr. Nanda in the meeting. And he has been with us for a long time, and all of us in the echocardiography have been inspired by him. And one of the reasons we all become good echocardiography is because reading his textbooks. And he's a very close friend of mine, and we have been in the meetings, dozens of meetings across the world. So it's always a pleasure to welcome Dr. Nanda in this session.
Thank you. Nanda?
Dr.
My
Nanda,
title
please.
is Distinguished Professor of Medicine.
Yeah, I think my talk has been pre-recorded, so
University of Alabama, Birmingham,
to start my talk.
Alabama. I'm going to talk on echocardiography and lung ultrasound in COVID-19. First of all, very important, one needs to look at the considerations and equipment. It's very important to have the personal protective equipment. It's mandatory. This protects the examiner, the echocardiographer. The other important point is to try to use the point of care ultrasound, which is much smaller in size, cheaper, easier to carry, and can be very easily sterilized. And when it comes to transesophageal echocardiography, it should be performed only if absolutely necessary because of the aerosol risk, and should be performed only when the cardiac window, acoustic window, is very poor. These are some of the examples of the handheld or pocket echo machines. Very small one here, one can carry in your pocket. This one is something like the size of a laptop, which is better than the previous one because it may have better resolution. When it comes to echocardiography, abnormal findings are seen in 60 to 65% of patients with COVID-19. First of all, we look at the chamber size. There may be increase in size of the left ventricle, left atrium, more importantly, right ventricle and right atrium. One can actually look at LV systolic dysfunction. We find contrast echo very useful to demarcate the endocardial border. And also very important now is to look at the global longitudinal strain using spectral technique echocardiography for both the left ventricle and the right ventricle. And this actually correlates with acute myocarditis, which you see sometimes on the cardiac magnetic resonance imaging. Also, there's left ventricular hypertrophy, which also may tell you that the patient may have cardiac edema. One looks at regional wall motion abnormalities, for example, acute coronary syndrome, acute myocardial infarction, or it may be due to stress cardiomyopathy, the so-called Takotsubo syndrome. And this, of course, when you see this, one needs to do a coronary angiography in most of these patients. And one can also look at the diastolic left ventricular function. RV systolic dysfunction is very, very important. Especially you can look at RV enlargement, RV dysfunction, the free wall dysfunction. Also look at the global longitudinal strain, and one can estimate the PA pressure. And if you see McConnell sign, then it also tells you that the patient may be having pulmonary thromboembolism. One can look at thrombi in other cardiac chambers in the right ventricle, right atrium, IVC, pulmonary artery. And one can get an idea of the fluid status of the patient by looking at the IVC size and collapsibility and calculate the right atrial pressure. Sometimes you see a very small IVC, and that's due to hypovolemia. And then we tell the providers to give the patient more fluid, which generally you don't need to give. Echo also helps in the placement of cannulas for ECMO. And of course, echo is very helpful if the patient had a previous echo for comparison purposes. This is an example of looking at RV free wall strain. In this particular patient, it was minus 16.35%. Normal should be more than minus 20%. Global longitudinal strain of the right ventricle. This is just to give an idea about not a patient with COVID, but just to a thrombus embolizing. Can have a right heart thrombus, which could embolize from the patron foramen navae into the left heart. This thrombus actually was in the left atrial appendage, undergoing cardiopulmonary bypass, elderly patient. And we were thinking whether we should take it out or not. This is the best two-dimensional technique we have, multi-plane transesophageal echocardiography. And you'll see when you see the thrombus, it will actually embolize by itself. It's much larger, has a much different shape than what we saw in the appendage with the best two-dimensional technique. And also gives an idea that if we had done a three-dimensional echocardiography in this patient, then we would not have any problem in actually visualizing the whole thrombus, including its size and shape, and then the surgeon would have no problem going and taking it out because the thrombus is large. At this point in time, the surgeon thought that the thrombus was simply something like the size of the tip of a finger, and therefore was not very mobile, so maybe you shouldn't take it out because that would mean opening the heart. When you do coronary bypass surgery, you do not actually open the heart, you're working on the surface of the heart. So this thrombus actually, as you can see, embolized into the pulmonary, into the systemic circulation. And of course, the surgeon was sweating. We did the cardiopulmonary bypass surgery. And then after bypass surgery, the very smart surgical residents were able to feel the pulsations, and they found that the left femoral pulsation was absent. And so what they did was to actually, they knew where the thrombus was and took it out. And the patient did not suffer any clinical sequelae at all. From this, the patient did very well. But just to show you, three-dimensional echo is very good. But also to mention at this point also that when it comes to COVID patients, you don't want to do a three-dimensional echocardiography because it will take more time. But in some instances, you may have to do that. So just to give you some idea about visualization of the thrombus by echocardiography. So where is the usefulness of echocardiography? First of all, it helps in guiding therapy. For example, if there's a pulmonary embolism, you know what to do. ECMO positioning of the impeller catheter for ECMO, looking at the fluid status, looking at the inferior vena cava. And of course, when there is RV dysfunction and poor cardiac output, you can get an idea that maybe due to hypoxemia and high positive and expiratory pressure ventilation, and should give you some idea. It may actually help you decide on the ventilation management. Most important also, it may help in deciding the need for cardiac catheterization or coronary angiography, because what you see, you may see wall motion abnormalities, and then coronary angiography becomes very, very important. And of course, the wall motion abnormalities will be due to coronary artery disease or unstable plaque, which has ruptured because of the instability of the plaque, because of the COVID-19 itself, producing myocardial injury, and doing that, or it could be sometime due to Takotsubo. And of course, you look at the cath monitoring of right heart pressures versus more conservative management. All this echo can help you in management. Include gross valvular stenosis regurgitation, which the patient may previously have and now has developed COVID. More important also is to do a follow-up echocardiogram after hospital discharge, because some of these patients have lingering symptoms. They may have some cardiac problems, they may have some fibrosis or edema, and echo might be very helpful. Of course, people have done MRI also. MRI has found also to be very useful in looking at fibrosis after the patients who have been discharged still actually have persistent symptoms, or they develop symptoms a few days after discharge. There is actually a sort of a New York and Italian study. What it showed was, and of course, when it comes to high troponin, that means there is myocardial injury. So that is one thing, you know, that there's something wrong with the heart there. And they found in this study major echo abnormalities in 65% of patients they studied. And they found that also, importantly, the in-hospital mortality about 55 times higher for those with versus without troponin increase, and increased 6 times in patients positive for both troponins and major transthoracic echocardiographic abnormalities. So if you actually take the troponin, high troponin, which is an indicator for increased mortality, but you combine that with echocardiographic findings, the mortality increased by 6 times. So therefore, echocardiogram is very, very important to these patients in terms of prognosis. And then they found also that after adjustment for complications like acute respiratory distress, shock, or acute kidney injury, the addition of transthoracic echocardiographic abnormalities to increased troponins more than triple the risk of in-hospital mortality. So that's very important. So therefore now, in addition to doing some looking for troponins as a sign of myocardial injury, adding to that, transthoracic echocardiography becomes very, very important. Here is another study. These are all published in last month, in the last couple of months. They found that adverse right ventricular remodeling, for example, RV dilatation or dysfunction, or TAPSI actually, was independently associated with 2-fold increase in risk for mortality in multivariable models. So again, doing an echocardiogram in these patients with COVID-19, when there is some evidence for a myocardial injury on the basis of increase in troponin, may be very important. So they also suggest now the echo should be done in all patients with COVID, not just with suspected cardiac ischemia, because it provides prognostic information, which is very important. But however, you know, these are a couple of studies. More studies are needed to further validate whether this is going to be true or not. But at this point in time, it looks like it may be important to do echocardiograms also in some of these patients. So here is kind of from the Journal of the American College of Cardiology to show you about the hospital admission, hospitalization. So first you do is troponin measurement, and this actually gives you strict, it's a risk stratification algorithm to potentially guide management strategies. So when there is increased troponin levels, that means there is myocardial injury, and then you do 3 things. One can look at other inflammatory biomarkers measurement, for example, like C-reactive protein, interleukin-6, ferritin, D-dimer, and procalcitonin. Then can look at ECG abnormalities, ST elevation or depression, conduction disturbances, low voltage. And thirdly, very important, also look at the transthoracic echocardiogram, where you can look at echocardiographic abnormalities, all the abnormalities that I mentioned, LV wall motion abnormalities, global LV function, diastolic dysfunction, even more important, RV dysfunction, and pericardial effusion. And these all will tell you that there's increased hospital mortality. So if you're looking at prognosis, a transverse echocardiogram becomes quite important. Now, let me go on to the next part of the talk, which is actually about lung ultrasound. And lung ultrasound actually should be done, can easily be done as a supplement to echocardiography, because when you are looking at the heart by putting the probe on the chest, all you need to do is move the probe towards the lung, like here some of the zones here, anterior zones, lateral zones, depending upon the, look at the mid-clavicular lines, anterior clavicular line, and the posterior clavicular line, and you can look at these zones on both the left and right lung. Now, lung, of course, does not actually, would not, with the lung, does not actually allow penetration ultrasound. So you will get only, because of the high acoustic impedance between the heart and the lung, you will only get some artifacts. But if there is water in the lungs or some other abnormalities like consolidation, then it becomes very different and you can make a diagnosis. One should also examine the back of the patient, the patient sitting up for pleural effusion, and might find a place where one can actually drain the pleural effusion without causing any problems, any lung problems or any other injuries. So normally this is what you get. You actually see the chest wall here on the top where you can see my arrow. And then you have the pleura here, which is thin. Normally it's very thin. Abnormally, it will be thickened and irregular maybe. And then you get these artifacts, which are actually parallel artifacts below the pleura and going all the way down. So this is the normal thing you get when there is no water in the lung or no consolidation or other abnormalities. But if you have some abnormalities, then what you get is there's water abnormalities. You get different type of artifacts. These are common type artifacts, which are called B lines. The normals are called A lines, which are parallel lines. That means there is nothing in the lung. You don't see any abnormality. And here actually you see B lines, which are comic type of artifacts. They tell you that there is some water in the lungs, which you can get with the interstitial lung syndrome, as well as with any pulmonary edema. Any type of pulmonary edema on the basis of cardiac or any other lung problems will get these B lines. And many times these B lines can be multiple and confluent, like you can see this. But when you see B lines, that means there is water in the lung. That's very important to remember. So that's an abnormality. Now, of course, you can also get consolidation. Consolidation looks like when you do an echocardiogram, the subcostal view, you see liver. You look at the texture of the liver, the consolidation also will have the same texture. So you can easily diagnose that if there's a peripheral consolidation like here, and you can see that on the chest X-ray also. And also you get these very high echogenicity. These are we call air bronchograms because there's some air there. It produces high echogenicity because high echogenicity. But you can make a diagnosis of consolidation very clearly. And as you know, with COVID, you get this consolidation pneumonitis, and many times it's preferentially on the surface of the lungs, not within the lungs, not downstream within the lung. So therefore, they're easily detected by lung ultrasound and may not be that easily detected by CT scanning. Although CT scanning is very, very important, no question about that. But you can, this peripheral consolidation, you can easily detect with the lung ultrasound, LUS. You may not, any consolidation below you can't detect because of course the lung will not allow penetration of the ultrasonic beam. And this of course will show you pleural effusion, which is very easy to diagnose. You can see fluid level here, and this is collapsed lung floating in the effusion, and that's the diaphragm here, that's the liver. So you can see the texture of the liver, and you can compare it with what we saw in the lung and in patients with consolidation and compare it. So lung ultrasound is very critical in COVID-19. You can start at pleural line, which B lines extend perpendicularly from the pleural line, radiating deep lung fields, and then you have these confluent B lines. Then when you have alveolar interstitial syndrome, AIS, you see these confluent B lines in more than 2 consecutive intercostal spaces. You can also diagnose pneumothorax, which you can miss on the chest X-ray. If you do an M mode for that, that's very interesting. You do an M mode, and for pneumothorax, you get a stratospheric sign. Normally, you'll get a beach sign. I'll show an example of that. If you look at the right side here, right lower corner here, this is actually the beach sign. So this is normal lung, the M mode. When there is abnormality, you do an M mode, you get these stratospheric signs different from the beach sign. So you can make a diagnosis of pneumothorax. Also, there's no sliding. Usually, when you put the ultrasound, the lung will slide as the patient breathes in and out. But when there's pneumothorax, anytime there's a pneumothorax, any part of the lung, you would see that the lung sliding is absent. And these are, of course, same example that I showed you before, of the B lines and consolidation. So the lung ultrasound is very interesting because it's safe, quick, low cost, no radiation, reproducible, and can follow dynamic changes in lung consolidation, can identify the best site for puncture in pleural effusion. and identifies pneumothorax, which carries poor prognosis. But remember, the B lines will detect only the lung periphery, not actually go down into the further down into the lung, only the periphery. But in COVID-19, there is preferential consolidation in the periphery of the lungs, which can be detected by lung ultrasound. So many times people have used their lung ultrasound scores together with the clinical findings as well as arterial oxygen levels, and actually they can actually differentiate which patients may require intensive care, which means admission to CCU or intensive care unit, mechanical ventilation, or mortality within 30 days. So as I mentioned before, the lung ultrasound may be more sensitive than CT for pleural and subpleural abnormalities, but let me not get wrong. CT scanning is very important, but on the other hand, you may actually decrease the need for multiple CT scanning and taking multiple chest X-rays using a lung ultrasound. And here is the last slide that I have here. It shows someone presented an abstract at the American College of Emergency Physicians just last month, and they said that lung ultrasound beats chest X-ray in making COVID-19 diagnosis, because sometimes, as you know, some of these tests have false positive and false negatives. So we are not sure whether this is COVID or some other type of lung pathology the patients come in with, or some cardiac pathology. Then you can actually do the lung ultrasound. If you see consolidation, pneumonitis, then you know this is definitely COVID-19. And they found that lung ultrasound has sensitivity of 97% compared with chest X-ray, which had a sensitivity only 70%. So lung ultrasound was better in this way. Now, this is, of course, just few studies, and more studies are needed. But just to show you, but it tells you right away that lung ultrasound is very important. As an echocardiographer, it's very easy for you to do that. You don't have to depend on somebody else, someone who does peripheral ultrasound to do echocardiography. You can do it yourself. You are doing an echocardiogram using POCUS. You can move the transducer around in the lung fields and take a look and see whether you see any B lines or you see any consolidation. So this is just to give you some idea about the value of echocardiography. Very important for managing patients. Echocardiography, very important for prognosis, especially in patients who have high troponins. And lung ultrasound also very important because it can decrease the need for chest X-ray or CT scanning, can detect actually water in the lungs, edema, pulmonary edema, and also ejects consolidation. In addition, of course, to looking at looking at pneumothorax. Also very important, which I want to stress, that pleural abnormality is very important. When you have actually pleural, like here, for example, here, you can look at right here in the middle here, B, you can look at pleura. It's quite thickened here and very irregular, like here also very thick and irregular. So if you see pleura which is thick and irregular, then you know that is pleural involvement. That also may help in diagnosis of COVID-19 when some clinical findings and other tests may not be equivocal. Thank you very much for your kind attention.
Protection do you take while doing the ultrasound for the corona patients?
I think you take full protection. You put on a gown, of course, put on a mask, put on a face shield and gloves, and so you really have to take full protection. None of our technologists so far have had COVID from the hospital. We have a couple of 2 or 3 technologists who did develop COVID, but that is from outside because they had some other exposure, not from the hospital. So that's very important. And also very important to make sure the machine is sterilized. So you can go for a smaller machine, easy to sterilize them. And you can keep one machine, if it's all feasible, dedicated for COVID patients also. So personal protection is very important to take the whole, because you are very close to the patient. And of course, if you are doing the transesophageal echo, that is really, we're really very much scared of doing that because of the other problem. But so we really hardly ever do transesophageal echoes in these patients.
Okay. Thank you very much, sir.
Okay.
The last question, please, if there's any. So if there are no questions, we conclude this session. And the next session is how to record and interpret global longitudinal strain. And the speaker for this session is Dr. Sanjay Mittal. All of us know Dr. Sanjay Mittal is the Senior Director, Clinical Cardiology and Research at the Medanta, the Medicity Gurgaon. He has nearly 30 years of experience in the field of clinical and non-invasive cardiology. He has established the first heart failure clinic in the country. He's in charge of heart failure program at the Medanta. He's past president of IAE NCR chapter, member of numerous medical societies and professional organizations, more than 50 publications in various national and international journals, and he has served principal investigator, national lead investigator of several trials. Next, our chairpersons for this session is Dr. Padma Gulati. She's a member, American College of Physicians, India chapter, member IAE, fellow UP Diabetes Associations, and is a consultant physician at the Gulati High Hospital and Medical Care Center. The next chairperson is Dr. Smith Srivastav. He's a secretary, Chhattisgarh State API of Physicians, head department of cardiology, Advanced Cardiac Institution, Pandit JNM Medical College, Raipur, is winner of National Medical Gold Medal for the best paper at Jericon 2009 and has many publications. I'll request Dr. Mittal to start his deliberation and hand the session to the chairpersons.
Thank you, Dr. Manoria, for giving me the opportunity of presenting in the meeting. The topic I'm going to discuss today, as Dr. Manoria said, is the principles of strain and how to inquire and interpret them. As was very evident in the panel discussion, that this is something which we are all echocardiographers and clinical cardiologists looking up to find a solution specifically for heart failure with preserved ejection fraction. And also to come out with the ambiguity of the ejection fraction business in reduced ejection fraction. So the principles of myocardial strain is that, say, for example, if the length of the myocardial segment is 10 centimeters for predictive purposes, and during systole it reduces to 8 centimeters, there is a change of 20%. And this 20% change is a reduction of 20%. That means it is minus 20. And that is what this cardiac strain is all about. However, if the length increases to 20% during a process, then the strain is plus 20. So we all understand during cardiac systole, there is a shortening of the myocardial segment, and that is why the strain, the longitudinal strain, which is measured during the length of the myocardium, is negative, and the normal value is around minus 20. So what happens here is that if the myocardium segments are taken, the machines today are actually looking at the speckles. All these myocardium segments are made of speckles, fine dots. And these dots can be enlarged by the machines and they can be tracked during the cardiac cycle. And what happens is that during the cardiac cycle, all these tracked points or speckles are not only tracked during the systole, but also there are new points which can be added during the cardiac cycle. And that is what makes the complete assessment of speckle tracking during the cardiac cycle. When we look at the left ventricle strain can be measured into 6 segments. All these segments are color coded, and all the speckle trackings during these segments are graphed in accordance to the change of the rate of strain. And this can also be drawn into a graph form, which shows that this apex, if you look at the purple one and the green one, they are the apical segments. They started the contraction earlier and later on the basal segments, and the red one means minus 20. So you can actually plot all the strains into the graph, which means the maximum and the minimum strain, as well as in the graphical format. So there are 3 different kinds of strain which we can measure, because the cardiac motility is in 3 different dimensions. One is the longitudinal, that means from the base to the apex. Second is circumferential, that means the heart also narrows down. And the third one is the radial strain, which means the thickening of the myocardium. So in systole, as we all know, the myocardium thickens, that means the thickness increases. That is why the radial strain is always a positive value. Whereas the circumference, which shortens during systole, as well as the length of the myocardium, which also shortens during systole, is a negative value. There are a few pointers which I would like to highlight here. During the image acquisition, usually the strain can be done offline. The image has to be acquired. So the principle is very important. Garbage in is garbage out. So we have to be very cautious on the acquisition of images. The image required has to be longitudinal in 3 apical views for the longitudinal strain, which means apical 4-chamber, 2-chamber, and 3-chamber view. There could be circumferential strain, and radial strain, which we have to look at 3 short axis levels at the base, apex, and mid-level. Second thing is all the images should be ECG gated, and at least 3 cycles should be taken with a uniform heart rate. Mind that atrial fibrillation is going to be leading to a major problem. The frame rate of the acquisition should be around 40 to 70 for the best utility. And the image quality has to be optimized. Otherwise, if we don't see the endocardium too well, there would be a problem. So good left ventricular wall endocardium with delineation, minimize the depth. The breath should be held just for 3 beats, that is, or 3 seconds. Avoid foreshortening and rib artifacts. Otherwise, this is, again, as I said, garbage in is garbage out. For example, this is what I give an example here. A wonderful image, 4-chamber, no foreshortening, endocardium is beautifully seen all around. Here, well, I can see the endocardium here, but the images are blurred at the apex. We have to get it better to get the better utility. But on the left corner, if we look at the images, you can see, I can't see the endocardium here. If you produce such kind of images for the analysis of GLS, it's going to be a negative study, and we have to be very important to manage the image quality before we go for the GLS. Second thing is endocardial border. The step is to delineate the endocardial border and give the machine a little bit of learning. If we do not delineate the endocardial border, like this here, endocardium is inside and the border is outside, you will get wrong results. So be very cautious in delineating the endocardial border. The third thing which we have to look at, that it should be LV wall only. Here, you look at this particular image, the papillary muscle has been incorporated, and this would give a wrong reading. So ideally, only the left ventricular wall, the septum and the left ventricular wall should be delineated. The fourth caution is that the proper contour of the left ventricle has to be again recorded. And if at all there is a change by some machines, we can change the contour to suit our perception. Otherwise, it's going to give us a wrong reading again. The fifth one is that we have to be very cautious on putting the annulus markers. Mind it, this is the landmarks which we are giving the machine for the analysis. So the marker should be like this, from the base of the mitral valve to the other base of the mitral valve. If we, for example, in this patient, the base of the mitral valve is here, but the ROI is going beyond that, this is wrong. And this is going to give us a wrong reading, especially in the basal segments. Similarly,
Dr. Mittal, 2 minutes left.
Yes, similarly here, the aortic route is going wrong. So the global longitudinal strain, it could be thereafter identified. We can have a bullseye plot where we can have the global longitudinal strain. Here in this particular patient, it is -14, but also we can have segmental longitudinal strains here, which can come out and give us a little bit of idea of which segments are not contracting as well as the other ones. The same thing can be plotted in the graph. As I said, one more thing which I would like to mention here before I end my talk, the rotation and torsions also can be measured. And the problem is, as is going to be here in this particular view, the base contracts counterclockwise and the apex contracts clockwise. And this torsion of -5 and -10 adds up to about 15 degrees or torsion base to apex and can also be identified. So, ladies and gentlemen, my last slide. The normal values of strain parameters are the circumflexion strain is -25 to -30. The radial strain is +50 to +70. And the area strain is -30 to -50. The apical rotation is +10 and basal rotation is -5, amounting for total strain of rotation of about -15. And last but not the least, the normal values globally are accepted that 18 to -20 is normal. Less than 15 is definitely suggestive of LV systolic dysfunction. Thank you.
Congratulations, Dr. Mittal. That was very easy explanation of a very enigmatic term. Often, strain and rate imaging is taken as something which is not done by every echocardiographer. I'll have only one brief question to you. What is the advantage of having a strain GLS rather than having a normal left ventricular ejection fraction that we have been comfortable for so many years?
All right, so that's a wonderful question. The problem with ejection fraction, it is too much operator dependent. And it varies very much with the volume loading conditions. On the other hand, the strain, longitudinal strain specifically, is a machine observed parameter. We do need to practice the art of delineating the ROIs and the annulus and the region of interest to get the best readings, but it is more operator independent for that matter and can be utilized in long-term studies for the regional as well as longitudinal ventricular functions.
So if there are no questions, we pass on to the next session. And the next session is on strain in aortic regurgitation and mitral regurgitation. The speaker for this session is Dr. Santanu Gupta. He's working at Sengupta Hospital and Research Institute, Nagpur. He's a reviewer of several journals, governor of CSI Eco Council 2018-20, past president CSI Vidarbha chapter, president DI Vidarbha chapter, and he has many publications and his areas of interest, Patley's heart, pregnant heart, etc. The chairpersons for this session are Dr. Rajiv Varghese. He's a chief cardiologist and CEO of Match Heart Center, Kochi, professor of medicine at Sri Narayan Institute of Medical Sciences, Kochi. His areas of interest are non-invasive and interventional cardiology and is practicing for the last 20 years. The other chairperson is Professor Sandeep Rai, professor and unit head, PG Department of Medicine, MGM Institute of Health Sciences, Navi, Mumbai. He's a keynote speaker, United Nations and WHO-sponsored Global Health Conference, and he has received Dr. APJ Abdul Kalam Lifetime and Achievement Award for research publication and national funding. I hand over the session to the chairperson. Please start the session.
Good morning to all. Thank you, Dr. Manoria.
Welcome, Dr. Santanu Sengupta, and thank you, Dr. Manoria, for organizing such an informative conference. Dr. Santanu Sengupta.
Yeah, I'm just
you can kindly start
my screen. 1 second. So, Dr. Manoria, thank you so much for this invitation. My slides are seen. Can you see the slides?
Yes.
Yeah.
Yes, sir.
So, Dr. Mittal briefed about the strain analysis. It was very good, and I'm going to focus on the importance of strain in the valvular lesions of mitral regurgitation and aortic regurgitation. Now, assessment of myocardial function in context of valvular heart disease has been challenging, and LVEF is often unable to disclose the initial LV dysfunction in this group of patients. And the current guidelines recommend valve replacement or repair in presence of symptoms, or if there is a reduced ejection fraction, but the resolution of symptoms or recovery of LV function post-surgery may not be reliably predicted. Now, as the components of cardiac deformation has been defined as longitudinal, circumferential, and radial, uh, the predictors of LV strain in volume lesions, peak strain values increases with increasing preload and increasing contractility, while peak systolic strain decreases both with increasing ventricular size and afterload. These are very important because both the lesions of MR and AR are volume dependent lesions. So let me focus on mitral regurgitation. Degenerative mitral regurgitation is a common and a progressive valve disease which has been difficult to manage. And the current guidelines indicate surgery in all symptomatic patients with severe MR, or if the patient is asymptomatic, if he has LV ejection fraction going below 60, LV and systolic dimensions of more than 40, if there is atrial fibrillation, or if there is evidence of pulmonary hypertension. And this is the guidelines which have shown the use of surgery in MR. And as you can see, they have divided into primary MR and into secondary MR. But there is some component called the asymptomatic stage or stage C, where they have focused that if the LV ejection fraction is maintained, or if there is, I mean, if you can see, if these things are not there, then you go for a periodic monitoring. But this ACC-AHA guidelines, which came in 2014, doesn't incorporate the use of global longitudinal strain. So valve repair in primary MR is considered reasonably low risk in asymptomatic patients with preserved LV ejection fraction, but the optimal timing of this procedure remains controversial. So let's have a case of a 44 years old male, non-diabetic, normotensive, absolutely asymptomatic, came for a pre-insurance assessment, has a systolic murmur. And as you can see, this is an echo. The LV ejection fraction is 62 and the LV ends systolic dimensions are 38. But as you can see, this patient has a significant MR, couple of more images. There are multiple flows quantifying it to be a severe mitral regurgitation. The global longitudinal strain, which is the cutoff, is around -19. In this patient was around -15. The patient was asymptomatic, but the cardiologist thought that he should go for a mitral valve surgery in spite of the guidelines. The patient didn't go for it, and interestingly, 8 months later was admitted with acute LVF in an atrial fibrillation. And as you can see, these are the images. This patient is in AF. You can see there is a decrement in the LV ejection fraction, of course, because of atrial fibrillation. The MR is there. This patient had a strain of -50. So why do we need something more than LV ejection fraction? The LVEF is often overestimated in mitral regurgitation as it simply reflects the entrance and the exit of blood in LV. Therefore, LVEF may remain in normal or supernormal range for longer periods in this group of patients. Earlier detection of LV contractile dysfunction is of pivotal importance and favors surgical correction of chronic MR in a timely manner, which theoretically restores normal LV function and life expectancy after surgery. And these are a few data on the use of LV strain in asymptomatic severe MR. So in this paper, they suggested that if a preoperative GLS of less than -18, that means more towards the positive side, was an independent predictor of post-operative LV dysfunction. So the cutoff was -18. More work here, a cutoff of -19.9 was demonstrated to have a major independent predictor of long-term LV dysfunction. So this is more cases. This patient had, again, asymptomatic, severe MR, LV and systolic dimensions of around 40. Global strain was -22. The patient, so this was a new study which was presented in JACC imaging, and they have said that they're focusing on asymptomatic patients who are having severe MR with LV and systolic dimension of more than 40. And as you can see, if the LV and systolic dimension goes on increasing, goes for surgery. But if it is between 40 to 45, or the LV ejection fraction is more than 60, and if there is a new onset AF as the previous patient, or has a PA, pulmonary arterial hypertension, goes for surgery. But if it is no, then a GLS cutoff of -19 has been taken and has been suggested. If it is preserved, you can follow up. But if it is less than -19, like -18, -14, then this patient should be subjected for a surgery, even if the LV ejection fraction is maintained. coming to AR is again a chronic volume overload, which leads to progressive LV enlargement and LV dysfunction. And the current guidelines indicate surgery in symptomatic patients with severe AR, or if the patient is asymptomatic, when the LV ancestral dimension is more than 50 mm, or if the LV ejection fraction decreases below 50%. So this is the guidelines of AVR in AR. As you can see, you have to look at all the parameters. But in asymptomatic case, it says that if you're going for other cardiac surgery, then you can go for AVR. But if these are the things which have focused on LV ejection fraction and LV and systolic dimensions and LV end diastolic dimensions, but there is no role of strain in this 2014 guidelines. So a case, 40 years old, hypertensive, since 3 months, no symptoms, occasional smoker, and as you can see, this patient has aortic regurgitation with this kind of dimensions, a preserved LV ejection fraction of around 55%. But the global launches strain was going down. It was around -15. The patient was advised follow-up according to the guidelines and with an optimal medical management. But 2 years later, presented to the OPD with NYHA class 3 symptoms. And as you can see, this patient's LV ejection fraction has gone down. It went to 55 to almost around 40, 45. And these are more data, EF going down. So in AR, the compensatory increase in stroke volume consequent to augmented volume load and increased sphericity of LV is responsible for a prolonged maintenance of global circumferential function and hence the LV ejection fraction. And at an early stage, a decrease in LV function starts in the subendocardium, where the GLS can be helpful and can give you an understanding of looking at the LV dysfunction by looking at the global launches strain. So these are the reports which have shown that reduced myocardial strain, systolic strain rate, and early diastolic strain rate can be associated with disease progression during conservative management with impaired outcome after surgery. And the cutoff here has been given as around -18 as a best cutoff for identifying disease progression, and a cutoff of -14 was a predictive of poor outcome in patients of asymptomatic severe AR who are going for aortic valve replacement. More data from Dr. Tom Marwick showing that in patients in moderate to severe AR, resting LV strain and exercise tricuspid TAPSE and an RV strain at rest are all independent predictors of early AVR. So let me conclude that a proper timing of mitral valve surgery in degenerative mitral regurgitation who are asymptomatic and aortic valve surgery for asymptomatic severe AR remains still controversial. The practice of observing these patients and waiting for symptoms to occur or an echo parameter for decrease in LVF has been called into question now, and strain imaging does provide incremental information in identifying subclinical LV dysfunction in this group of patients and can help in optimizing the timing of surgery. Thank you so much.
Thank you, Dr. Sengupta, for this very informative session on your echocardiography. I'll request Dr. Varghese to kindly unmute and if you want to have some views or comments.
Thank you, Dr. Santanu Sengupta. It was a very lucid and comprehensive presentation of the strain in MR and AR, which we commonly encounter in our clinical practice. And the parameters that you have mentioned are absolutely precise, and that's what we have to clinically go by. Although we have to combine it with our clinical decisions to make a judgment. Of course, we see that the ejection fraction is actually an overestimation of kind of an underlying LV dysfunction. So the moment we see that the LV function gradually comes down from 55, and then once it almost touches 50, based on the other clinical parameters, we have to make a decision, to take the patient up for surgery. So I would just conclude with these remarks, and maybe if any questions from the audience would be welcome. Thank you.
Dr. Santanu.
Yeah.
Dr. Santanu, is the value of GLS different for rheumatic and primary MR versus secondary MR?
Yeah, so Yeah, in rheumatic MR and rheumatic AR, the data is not sufficient. It's not available much. The thing is, as you can see, these are work which has come in last 2 to 3 years, and most of them are coming into the degenerative component. Maybe I think that's going to be a future for us to work on, where isolated rheumatic MR or an isolated rheumatic AR, which is very difficult to get now. Also, we can look at the LV strain. I would like to have Dr. Nanda's opinion about this also. Is Dr. Nanda there?
I don't think he will be there. So with this, we conclude this session. Dr. Nanda, are you there? Okay.
No, I was just going to, I think what you mentioned is correct, but some of the studies have been done when the strain had not been standardized among various vendors. And also there was a problem with reproducibility. So I think newer studies are needed for that. Because, for example, you can see somewhere it was mentioned like minus 19% or minus 17%. We know that's actually normal now. We can't consider it normal. So I think these data do point that strain is important, but those values may not really be that valid right now. And maybe further studies are needed. Okay.
Sir, can I ask a question?
Last question, please.
If a patient is having combined AR and MR lesion, okay, if there is a combined lesion of MR and AR, can we quantify how much strain is by MR and how much by AR?
I think it's a very challenging situation because both are volume dependent lesions, and this kind of patients will have a faster. So let's say if you're dealing with both severe MR and severe AR, they progress very fast. So we don't have much data about looking at subclinical LV dysfunction in patients of both severe MR and AR. But yeah, it is a valid point. These patients do progress very fast.
With this, we conclude this session, and the next session is on assessment of left ventricular diastolic function, what's new, and the speaker for this session is Dr. Manish Bansal. Manish Bansal, as all of us know, is trained at premier institutes in India and abroad. He's a recipient of numerous awards and honors. His areas of interest include atherosclerosis, CV assessment, advanced echo. He has keen interest in academics and research, and he has nearly 200 publications, including approximately 80 on PubMed. He has been a mentor to students undergoing training in cardiology and echo at the Vedanta. He's invited as a faculty in various national and international conferences. And the chairpersons for this session is Dr. Parthu Sarkar from Kolkata. He's professor, Department of Medicine, Calcutta National Medical College, Secretary West Bengal branch of IRA, Treasurer West Bengal API, EC member IACM, and life member of CSI and ISCCM. And the other chairperson is a very senior cardiologist from Hindu Sabha Hospital, Ghatkopar, Mumbai. He was past secretary, Indian Society of Medical Ultrasound. He has cardiology experience since 1975 and 45 years of experience in clinical cardiology. I hand over the session to the chairpersons for conducting the session. Dr. Sarkar and Dr. Modi.
Hello. I invite Dr. Manish Bansal to give his talk on LV diastolic function assessment. What is new in 2020? Dr. Manish Bansal.
I'm audible? No, video no.
Yes.
Yeah. Good morning, everyone. I thank Dr. Manoria for giving me the opportunity and for the kind introduction. We all know that assessment of LV diastolic function is an important goal of any echocardiographic examination, particularly in patients who present with symptoms suggestive of heart failure and routine conventional echo does not show any obvious pathology. So in such patients, careful evaluation of diastolic dysfunction is very important. But at the same time, we also know that assessment of LV diastolic dysfunction has been very challenging, and therefore to simplify it, various societies have published various algorithms and guidelines. This is the 2016 ASC EACVI recommendation. The guidelines suggest that in patients who have normal EF, don't have myocardial disease, in them we should first determine whether the patient has diastolic dysfunction or not. And for that purpose, these 4 key parameters are recommended, which include E over E prime itself, TR velocity, and LA volume index. And based on that, we decide whether the patient has diastolic dysfunction or not. Once we realize that the patient has diastolic dysfunction, and also in patients who already have myocardial disease or reduced LVEF, we go to the next algorithm to decide the grade of diastolic dysfunction and to estimate LV filling pressure. And for this, we begin with mitral inflow pattern, and using mitral inflow pattern, we can straight away identify either grade 1 diastolic dysfunction or grade 3 diastolic dysfunction. But in intermediate cases, we look at other parameters to further classify the grade of diastolic dysfunction and estimate LV filling pressure. The main objective of this 2016 document was to simplify diastolic function assessment as compared to the previous recommendation, which was published in 2009 and was believed to be complicated. This 2016 recommendation actually did simplify it, but it too had its own share of controversy. And this is a very recent publication just this year itself, which says, which is actually a debate, and investigators like leading investigators like Dr. J.O. from Mayo Clinic and his group believes that these guidelines require modification, and they have suggested an alternative algorithm which combines the 2 algorithms. But at the same time, Dr. Sharif Naga, who was the lead author of this guideline document, believes that there is no need for modification, but we need to apply the same guidelines in a more careful manner. Now, regardless of this debate, one thing is very clear, and that is that we need to improve the way we assess LV diastolic function in any given patient. And in this context, left atrial strain has emerged as a very useful parameter. Now, this is a measure of passive left atrial stretch and contractile function. The availability of speckle tracking echocardiography has made it very simple to estimate LA strain. This is a typical LA strain curve with different waveforms and components. Of this, the first peak here, this is the one we are interested in the most. This is known as LA reservoir strain. The normal value is 35 to 40% or higher. When it is less than 25%, it is considered to be definitely abnormal. Many studies have shown that LA strain correlates with LV diastolic function pretty well. This is a publication from echocardiography. Dr. Nanda is the chief editor of echocardiography, as we know. Publication from 2016 shows that LA strain correlated very well with invasively measured LV EDP. On the other hand, we did not find such good correlation between LV EDP and mitral E over E prime. So this clearly demonstrates that LA strain is a robust parameter of LV diastolic function. More recently, just this year, we had a very large study from Mayo Clinic, 669 patients with normal EF who underwent treadmill echo evaluation. And as we see here, there was reduction in LA reservoir strain with worsening grade of diastolic dysfunction. And more importantly, LA strain at rest also correlated with exercise response to filling pressure. The patients who had increased LV filling pressure even at rest had the lowest LA strain as compared to those who had LV filling pressure normal at rest and exercise and had the best LA strain. Now I'll show you 2 examples which demonstrate how LA strain adds to or complements other echo parameters in assessment of LV diastolic function. So this was a 72-year-old lady, diabetic, non-obese, presented with class 2, class 3 dyspnea of recent onset. We look at LV apical 4-chamber view, nothing gross except that LA appears slightly enlarged. The LA volume was 30 ml per meter square, which is on the higher side, but not clearly abnormal. Mitral inflow pattern suggests grade 1 diastolic dysfunction. E prime is reduced, but E over E prime is not in the abnormal range. So we looked at further parameters LV GLS was absolutely normal, and LA reservoir strain was also in the relatively normal range, suggesting that there was no advanced LV diastolic dysfunction in this patient. So on evaluation, her CT coronary angiogram was normal. She was found to have bronchitis, which improved bronchodilators and antibiotics. On the other hand, this patient, 66-year-old gentleman, hypertensive, hypothyroid, he was admitted with left MC infarct. There was no documented AF. When we did echo, mitral inflow pattern appeared to be normal, relatively normal. E prime was reduced, but E over E prime was not grossly abnormal, although it is on the higher side, suggesting that this was probably pseudo-normal pattern. We evaluated further. GLS was definitely reduced. LA volume was significantly increased, suggesting that he indeed had significant diastolic dysfunction. And if we look at his LA reservoir strain, that was also markedly reduced. When we are in doubt, we can also combine LA strain with passive leg raise. There are lots of papers on this now. In a patient who has got good LV diastolic function, leg raise increases LA strain, but in patients who have diastolic dysfunction, leg raise may cause paradoxical reduction in LA strain. So this patient, as we see here, has grade 1 diastolic dysfunction with clearly elevated LV filling pressure. If we look at LA strain, it is already reduced at rest, and on passive leg raise, it decreases further. So confirming that there is significant amount of LA remodeling and dysfunction. Now, the greatest value of LA strain lies in its prognostic value. It's been shown to predict AF risk very well. This is a very large study, nearly 2,500 patients who had presented with acute heart failure with normal sinus rhythm. Followed for 5 years, 16% developed AF. And as we see here, those who had reduced LA strain had significantly higher incidence of AF. And this separation of the two curves was seen in both HFpEF and HFrEF, and also in patients with relatively normal LA volume index and increased LA volume index. Not only the AF risk, LA strain also predicts embolic risk. This is another study, shows the same thing, that in patients who have AF, LA strain, reservoir strain adds significant incremental value to Chatz-West score in predicting the risk of cardioembolic stroke. And once patient develops embolism, LA strain also predicts survival. As we can see here, those who had reduced LA strain had worse survival. And this is a very recent study correlating LA strain with another important outcome, that is incident heart failure. A study from Australia, 758 asymptomatic elderly subjects who did not have any evidence of heart failure. Over 2 years, 10% of them developed heart failure. And as we see here, those who had reduced LA strain, that is less than 24%, significantly higher risk of LA of developing heart failure. And on multivariate analysis of all the echo parameters, only 2 were predictive of AF, that was LA reservoir strain and GLS. So this clearly shows the value of LA strain in diagnosing diastolic dysfunction and prognostic assessment. But as for any other parameter which is being developed only recently, we need more data about its practical utility in day-to-day clinical practice. But this is something which
Dr.
we can
Bansal,
start
2 minutes left
on relatively regular basis. Now, the other important thing is exercise hemodynamics. Most of the guidelines place a lot of emphasis on this. In any patient who presents with suspected heart failure, has normal filling pressure, we should exercise the patient, and we can assess the response either by echo or by invasive assessment. If you are doing echo, E over E prime going beyond 15 indicates LV diastolic dysfunction. As we can see here, this was a 72-year gentleman, diabetic, hypertensive, underwent PTCA for single vessel disease, but 8-9 months later, he presented with dyspnea. We did exercise echo. He exercised for 7 minutes, no angina, but had significant dyspnea. No ECG changes or wall motion abnormality, as we can see here. But if we look at his filling pressure, E over E prime was normal at rest, although E prime was reduced, there was diastolic fusion of E and A, indicating diastolic dysfunction. But look at what happened after exercise. E over E prime increased to 21, indicating marked increase in filling pressure. So that was the cause of his dyspnea. Another exciting development in the
from
field
11:15, I will unmute.
LV diastolic function assessment is ultra high frame rate imaging for myocardial stiffness assessment. So as we know, reduced myocardial compliance and impaired relaxation. These are the two main pathologies in LV diastolic dysfunction. Both of them have been very difficult to assess accurately using echo, but this new technology makes it possible to assess myocardial stiffness. What we do here is that we use a special probe which has the capability of image the heart at a very high frame rate, more than 1000 per second. So when we emit ultrasound beam, it traverses into the myocardium. It results in a shear wave formation. The speed of travel of that shear wave through the myocardium correlates with the myocardial stiffness, which we can measure clearly. So this is a study which compared patients with hypertrophic cardiomyopathy with healthy volunteers. As we can see here, myocardial stiffness increased with age in both the groups, but there was clear separation between the two groups, and myocardial stiffness had nearly 100% accuracy in diagnosing patients with heart failure with hypertrophic cardiomyopathy and differentiating them with the healthy volunteers. And lastly, I'll briefly talk about role of machine learning. In the beginning of my presentation, I showed you algorithms for assessment of LV diastolic function. We use similar algorithms not just for diastolic function, but almost everything in the medicine. Even for electrolyte disturbance, hypokalemia, hyponatremia, we use algorithms. Now, these algorithms definitely make it simpler for us to diagnose the abnormality and to find the appropriate treatment pathway. But these algorithms have a major limitation. These algorithms are based on the assumption that every patient will fall into one of these categories and will be able to go along this stepwise algorithm without any difficulty. But as we know from our clinical practice, it does not happen all the time. Patients have considerable overlap, and which leads us to a lot of confusion. So machine learning overcomes this problem to a great extent. What is done here is that a lot of data is fed to the computer. Computer looks at the data and tries to find the associations between different parameters, and then comes up with the clusters.
Dr. Manish, please conclude.
Okay, so last slide. If we find that if there's a cluster of abnormalities, we find that this particular problem is there. If there's a different cluster, we can make out that, okay, a different pathology exists here. So a lot of work is going on in this field. In ECHO, Dr. Partho Sengupta is leading this work, and this is his paper published last year in JACC Imaging, in which his group looked at 866 patients. 559 were those with preserved EF, and remaining were with myocardial disease or reduced EF. And if you look at this, this is HFpEF, and here we have HFrEF. This is conventional classification, the standard guidelines that we use, and this is machine learning algorithm. So if you look at any parameter, whether any mortality, cardiac mortality, any hospitalization, cardiac hospitalization, the current guidelines were not able to separate out different groups with accuracy, but machine learning algorithm clearly separated out different outcomes, both in HFpEF and HFrEF. So these are the key new developments in diastolic dysfunction, which I wanted to focus on. Thank you so much.
Very good, Dr. Bansal.
Please, one question only.
Yeah, I want
Dr.
to
Modi,
just
allow one question only.
Yeah, I just wanted to compliment the Bansal because he has really given a lot of new things. All these years.
Yeah, video
One question, please. One question, please, sir.
I'd like to just make one comment. Can I make one comment?
Can I ask
Yes,
a question?
yes. Yes, sir, carry on.
The comment I want to make is that you can also use lung ultrasound to diagnose pulmonary edema, subclinical pulmonary edema. Sometimes you don't hear any valves in the lungs, and patient is in left heart failure. And at that point in time, if you do lung ultrasound, you can pick up those comet-like echoes, and you can make a very clear diagnosis of pulmonary edema. So that is another thing that can be introduced into looking at diastolic dysfunction, especially left heart failure.
In fact, there is a study with exercise echo also, exercise echo with lung ultrasound and development of comets on exercise.
Right. Address for exercise.
Dr. Bansal, in the presence of atrial fibrillation, how do you decide about diastolic dysfunction in the presence of AF?
So for AF, we have different parameters. We can look at IVRT, that parameter remains applicable. We can look at pulmonary vein flow pattern, especially the diastolic wave and its deceleration time. If it is very steep, then it indicates diastolic dysfunction. And we can also look at E over E prime with a different cutoff value. We use 11 instead of 15. So these are some points that, and even E wave, if it is very steep, is steep deceleration, that again will indicate diastolic dysfunction.
That's good. Okay.
With this, we conclude this session, and the next session is Understanding the Myth of HFpEF by Dr. Santanu Sengupta, and the chairpersons for this session are chairperson was Dr. Sangram Brother from Gulbarga and Dr. Alok Rai from Raipur. Dr. Sangram Brother is Professor, Department of Medicine, MR, Medical College, Gulbarga, Karnataka. Publications in various national and international journals. He is editor general, APKI Journal of Internal Medicine, Karnataka, and the area of interest in cardiodiapology. Dr. Alok Rai is past chairman, Chhattisgarh State API. He is scientific chair and executive member, CGCSI, member of various bodies, life member of various bodies, and has participated in various national and international conferences. Over to the chairperson to conduct the session.
Can I share my slide? You have to understand. Perfect. So,
yes, already Dr. Sengupta has been introduced. Over to you, sir.
Yeah, so I think continuing with the spectrum of diastology, I wanted to share the role of echo in understanding HFpEF, a very challenging situation. And so why do we need to understand more deep into HFpEF? Because it is a heterogeneous disorder. And interestingly, the one size defined by diastolic parameters doesn't fit all. An echo diagnosis of diastolic dysfunction and HFpEF, as Manish was telling, has been challenging, and a lot of things are now evolving over a period of time. And we desperately are in need of some good treatment for HFpEF. Causes of diastolic problem, HFpEF, are these: coronary artery disease, hypertension, diabetes, obesity, sleep apnea syndrome. And there are some unique structural, functional, and ultrastructural changes which are there in between HFpEF and HFrEF. As you can see, the volumes are more or less preserved in HFpEF. The wall thickness are higher, the mass can be higher in both. The remodeling of LV is mostly concentric in HFpEF as compared to HFrEF, which can be eccentric. The stroke wall, ejection fraction are more or less preserved, while in ultrastructural form, the myocyte diameter starts increasing. And there is an amount of fibrosis. If you do an CMR studies, fibrosis in myocardium can be interstitial or reactive, while in HFrEF can be a focal or replacement kind of fibrosis. Now, the concept of cardiac performance, we have been discussing that heart has a cardiac output stroke volume, which we can look by an invasive Swanson catheter. And we now have, it can be defined as a compression pump, looking at the LV cath and 2D echo to understand the dP by dt or ejection fraction. There is some concept of tissue pump where we look at the biomarkers, looking at the BNP levels and more cytokines. And we have seen about the strain analysis, which can be picked up by an echo looking at the muscular pump. And we do have an MRI-derived strain also. And the time course of HFpEF also evolves, starting precipitated by the comorbidities and risk factors. And there is a lot of interplay of multiple mechanisms which causes changes in the cardiovascular system, from remodeling to stiffness to autonomic changes to dysynchrony involvement of the RV side. And there is a component of low reserve where there is a change in the preload and afterload changes, which changes in the heart rate variability. And the patients can have clinical problems of reduced quality of life, effort intolerance, lung congestion, recurrent admissions because of comorbidity, and ultimately mortality. Now, HFpEF is an interesting thing, and it is mandatory to see that LV involvement may not be there always. So the myocardial involvement in HFpEF is a spectrum. So if you have a cardiac cause, isolated cardiac cause of HFpEF, as classically seen in infiltrative cardiomyopathy, but you can have an HFpEF kind of picture in primary renal failure, liver failure, or patients who are morbid obesity. So this can in turn involve the myocardium, which are causes extra cardiac causes of HFpEF, a classical phenotype which has been identified. So this is Sanjeev Shah's paper. He divided HFpEF into 3 phenogroups: phenotype 1, phenotype 2, phenotype 3. The phenotype 1 is a classical BNP deficiency syndrome where there is a lesser cardiac remodeling and the BNPs may be normal. The second phenotype, which we mostly commonly seen, is the obesity or a cardiometabolic phenotype, where there is an involvement of the myocardium characterized by impaired myocardial relaxation. They do have high prevalence of diabetes. And the third phenogroup is mostly involving of the LV with RV dysfunction. The patients can have renal dysfunction. These patients have predominantly also are having atrial fibrillation. Now, why this is important? Because it has been seen that the prognosis of phenogroup 3, that is the one with RV dysfunction and atrial fibrillation, is the worst and almost all 3, and phenogroup group 1 may have a better prognosis. Now, anti-proBNP, there are caveats. 30% of HFpEF patients may have it lower than anti-proBNP than normal. We do get false BNPs in patients with increasing age. It can be higher in women than men, and BNP may be higher in atrial fibrillation. False negatives: obesity decreases BNP levels, and so does a normal anti-proBNP during stable phase of decrease preclude HFpEF diagnosis? The answer is no. So remember, even if you are clinically suspecting HFpEF, if the BNP is normal, maybe you're dealing with the BNP deficiency HFpEF phenotype 1 in this group of patient. Now, this is the group where the patients, this is the mechanism they have shown. You have a genetic tendency, lack of wall stress can be seen in Africans, predisposes to hypertension, fluid retention, and high adiposity across the thoracic and chest wall, giving to a HFpEF kind of syndrome. The phenotype group 2, this is a classical cardiometabolic syndrome. In this, the global Launches strains worsens with increasing number of factors. There is a classical diastolic dysfunction, and the LV Launches strain and the E prime velocity worsens with increasing wastage ratio. And this was presented in the Hypergen study, a good number of around 2,150 patients assessed. And the phenotype group 3, as I said, they are having a poorer prognosis, characterized with RV involvement, renal insufficiency, splanchnic congestion. AF can also be seen in sepsis and cachexia. They are mostly cachexia group of patients. Now, cardiac function parameters in HFpEF can be assessed by a lot of parameters: cardiac power output, cardiac index, but the most robust, which has been talked about in this meeting, has also been left LV global longitudinal strain, and there is more increment of identifying the LA strain in this group of patients. So HFpEF longitudinal strain is now defined as a marker of health of subendocardium. How good is your subendocardium? And as it goes towards positive, your subendocardium is not healthy. But if it is more than 19, you are having a healthy subendocardium. And this is the group of phenotyping of HFpEF. Again, from Partho's group, they said that if the LV ejection fraction is preserved, can also have HFpEF with reduced longitudinal strain, where the myocardium is involved more. But HFpEF can also have a preserved longitudinal strain, where the LV ejection fraction is maintained, global longitudinal strain is maintained, but still the patient has HFpEF, classically seen in primary left atrial cardiomyopathy, and can have isolated RV cardiomyopathy also. So this group has to be seen, that just labeling the patient as HFpEF with normal longitudinal strain is not sufficient. You have to look more. Yeah, we should start looking at the left atrial strain. So, abnormal LA mechanics, looking beyond LV, lot of data. Manish told about this value of the LV reservoir strain. One of the studies say that anything more than 31.2 has a better prognosis when these patients are followed up over a period of time. LA mechanics in HFpEF should be identified. Now, this is a second phenotype classification which was given by Barry Burlaw. He's from Mayo Clinic, and it was an ancillary study of the RELAX trial. And he divided them into non-obese HFpEF versus an obese HFpEF. And as you can see, the non-obese HFpEF, the obese HFpEF have a higher edema. They have prior heart failure hospitalization. NYHA is more than the non-obese, but the left atrial enlargement is lesser. And as reported by Sanjeev Shah, also the anti-pro-BNPs are lesser than the non-obese HFpEF. So there is a lot of interest in going into
Santanu,
this
2 minutes
group.
left. Sorry.
Yeah, I'm almost done. So what is the treatment? Why this phenotype treatment is important? Because if you have lung congestion, you go for diuretics, caloric restriction. If there is hypertension, start with anti-hypertensive drug. But the most important thing is exercise training program is now getting identified in this group of patients. There is also interest of looking at the pulmonary vasodilators. But if you tell me, I was searching at the report, a lot of data has come up that exercise training does improve diastolic dysfunction in patients of heart failure patient. This is more data about 3-month exercise training, improving quality of life in this group of patients of HFpEF. So can diastolic dysfunction and HFpEF be prevented? The answer is yes. If you have a good caloric restriction along with a proper exercise, you can maybe not halt, maybe delay the progression of diastolic dysfunction and HFpEF. So thank you. This is the ultra macroscopic image of a fetal neural heart at 6 weeks. And as you can see, the diastolic function assessment, maybe if you can look at them, we can be able to have more information. Thank you so much.
Thank you. Excellent talk. Over to chairpersons, please.
Thank you, Dr. Sengupta, for your excellent deliberation, making the topic crystal clear. Hardly there are any questions on the chat box. My co-chair for any comments. Kindly unmute, sir. Unmute and speak.
Dr. Alok Rai, please unmute yourself. Yeah.
Yeah. So you have Dr. Santanu has given an excellent and a very crisp presentation. My question for him is, you have alluded to the 3 phenotypes. The third one was atrial fibrillation. If you remove this phenotype, the prognosis in this subset of patients is better. Am I right?
No, actually, HFpEF and HFrEF, if you compare, both have a poorer prognosis. So the long-term 5 years survival of HFrEF and HFpEF is the same. But if you see HFpEF, in them the 3 phenogroups, the third phenogroup have the worst prognosis.
Worst prognosis. So
Dr. Shantanu, what is the role of diastolic stress echo in diagnosing HFpEF?
Right. I didn't touch upon because of lack of line. So if you are suspecting HFpEF, the patient is absolutely comfortable. The E by E primes are borderline. So this is the diastolic dysfunction assessment. And they have shown that if the E by E prime is around 9, 10, LA looks big, you ask this patient to exercise. You can do passive leg raising test. You can have a 6-minute walk test, or you can have a modified Bruce or a Norton protocol. And they have seen that if you exercise them, the E by E prime can change, the TR velocities can go up, and also if there is a myocardial involvement of the LV, even the strains go down. So yes, there is a role of diastolic stress test in unmasking in patients whom we have a very high suspicion of heart failure with preserved ejection fraction.
Dr. Spandan, you wanted to comment? Please.
My question is that in the phenotype 1, that is so-called apparent BNP deficiency syndrome, the overall prognosis is relatively better vis-a-vis that phenotype 3, where RV is involved more and the renal involvement is there. So whether the prognosis of HFpEF is more related with the level of BNP in the given patient.
Yeah, so BNP, anti-pro-BNP is a marker of the stretch of the myocardium.
Yes.
It doesn't mean that So you can change your BNP. So if you look at a BNP of a normal person, if you do a BNP in the morning at 6 a.m. versus a BNP in the evening 6 p.m., same
yes,
person, things are going to change.
Yes, yes.
So BNP is one of the robust marker which gives you information about the stretching. And so interestingly, HFpEF phenotype 1, even if they are having HFpEF, they may have a BNP levels to be normal or less than normal. So the point is, if you are having a high level of suspicion, and if you get a BNP to be normal, just don't think that this patient is doesn't have HFpEF. Go for more tests, as Dr. Manoria was telling. Go for an exercise protocol. Look at the LV strain. Look at the LA strain, and then try to dig out.
Since we have one more time, your comments from Navin Nanda sir on this.
I think my comment is that I think it's getting more and more complex. The whole topic of diastolic dysfunction. I think clinically, what's very important is echo is very important to say that the ejection fraction is normal, and then you diagnose heart failure on clinical examination. Left heart failure on clinical examination, you could use something like lung ultrasound, something more simple. And that, I think, is the best way to diagnose increased left-sided filling pressure. Because when we are talking about diastolic function, what is more important is not just relaxation abnormality, but increase in the left-sided filling pressure, because that's what's going to produce symptoms in a patient. So I think that's the simple way to go for it. And if you are still confused, then you go to these more complicated tests. And also very important to look at the inferior vena cava. If the inferior vena cava is dilated and not, that tells you that the right heart pressure is high. And as you know, they are both interdependent, left ventricular function and left ventricular diastolic dysfunction and right ventricular failure. They're all very interdependent. As was shown here in the phenotype 3, the right ventricle was supposed to be important. So so I go for some very simple things to diagnose increased left side. I don't call it diastolic grade 3, grade 2, no. I just call it increased left-sided filling pressure, because that's important, not just relaxation.
Thank you.
I mean, that's my view.
So we conclude this session now, and we move on to the next session, which will be on 3D assessment of RV geometry and functions, which will be taken upon by Dr. Rakesh Gupta. And Dr. Rakesh Gupta is a formerly cardiologist in the Thompson Jefferson University Hospital, Philadelphia, USA. He was a past president, Cardiology Society of India, Delhi chapter, past president, Indian Academy of Echocardiography, vice president, CSI India, and he's a cardiologist in JRO Healthcare Private Limited and Charak Heart City, Delhi. And the chairpersons for this session will be Dr. R. Manokar. He's a professor of cardiology at Sri Ramchandra Institute of Higher Education Research Center, Chennai. He's APG Abdul Kalam Award for Excellence in Cardiology in 2017, and he has many publications in various journals. And the second chairperson will be Dr. K.K. Varshne. He's a senior consultant cardiologist practicing at KK Intensive Care Hospital and Heart Center, Aligarh, for the last 30 years. And he's a fellow of CSI, IAE, and ISE, and he's a vice president of ISE. So over to chairpersons for conducting these sessions. Dr. Varshne and Dr. Manokar is there. I think they are missing.
I am there, sir.
Yeah, Dr. Manokar, please start the session.
Big thanks to Dr. Manoria for inviting me for this role. Dr. Rakesh Gupta needs no introduction to this august audience. He's a kind of a pioneer as well as a passionate echocardiographer. So I think it is appropriate that he takes over and lets us share his ideas on right ventricle, which we always call as the neglected ventricle. So over to you, Dr. Rakesh Gupta.
Thank you very much, Dr. Manoria, and my respect to Dr. Nanda and all my fellow colleagues and dear friends. We do not say anymore the neglected ventricle. I think is the most important ventricle in day-to-day practice. As we heard a few minutes back, whatever we are looking at is ultimately reflecting to the right ventricle in practice. So what we're going to do is we are going to look at 3D assessment of right ventricle and unfortunately, like I'm in a DMA office right now. Whatever the light we have is over here. So we are going to look at an RV function as geometry. Look, the precise evaluation of RV function in geometry was not possible with 2 dimensions echocardiography. Look at this subcostal window. We only can see one part of the right ventricle. Here in a 4-chamber focused view, we cannot see the RVOT as well as the subsequent. Various parameters for RV assessment, if you look at it, the important thing is RV volumes. We cannot look at the RV volumes in 2 dimensions echocardiography. Now they are possible and comparable to MRI in 3 dimensions echo. RV functions, TAPSE, RV free wall TDI and RV strain is possible with 2 and 3 dimensions echocardiography. And if I have to compile this together, like except for RV volume, all parameters has to be evaluated individually. Once they can be done all together in one go by 3 dimensions echocardiography. 3 dimensions echocardiography, it allows an accurate and complete assessment of right ventricular functions and size and the geometry. Look, this is a 3 dimensions echo which we cannot see by 2 dimensions echo. We can look at a septal leaflet, we can look at anterior leaflet, we can look at a posterior tricuspid leaflet, and we can look at the whole of the geometry. The only problem is we have to have a very good imaging quality if we are going to do a 3 dimensions echo. All this is possible, the evaluation is possible by machine-based software today. And this machine-based software, I hope I'll be able to show you today. And this is very good comparable with MRI, which are considered to be a gold standard. And if you look at an MRI, there is a comparison with 3D echo with MRI is, look, here is 3 dimensions echo, here's a cardiac MRI. If you look at a 3 dimensions echo, the end diastolic volume is 151 versus 176, leading to minus 25 ml, 80 versus 88, and 48 versus 53. If I look at these figures, the end diastolic volumes are there little underestimated, end systolic are close by, and there's a little variation in ejection fraction. So it's considered that overall it's a good correlation between 3 dimensions echo and MRI. We have this machine-based 3 dimensions echocardiography quantification of right ventricular size and function, and that is validated against a cardiac MRI by this paper published in 2019 in American Society of Echocardiography. Let's see how do we do it. I'll try to show a live demonstration by changing my scenario from this to a machine-based demonstration of 3 dimensions echocardiography. I hope every one of you can see my screen over here, and we can look at this and try to get a real 3 dimensions what I was talking about. And look, I'm able to get this 3 dimensions picture of a RV over here. I'll emphasize this thing again and again. Look, the acquisition of 3 dimension image is an important issue. Then we go to measurements, and once we go to the measurement, we go to volumes, and once we go to volume, we go to 4 dimensions RVQ. Once we go to the 4 dimensions RVQ for analysis of RV in this particular fashion, then we have a certain markers you can see on a screen. We try to pull this marker to the center of tricuspid valve, then bring this line to the center of this apex. Once we are done with this, we go and look at this other view. We do the same thing in other view and bring it down to this level. Here is the image itself tell you that you have to bring this image almost the way it has been shown in the picture formats, and the same thing is shown over here in a pictorial format, and that's how we do and this kind of a thing. One point which we always face difficulty is this part of the RV is if we do not acquire accurately, this part of the RV we start losing it every time. And this is the apex which we lose a number of times when we do not align. Then we go set the markers. Then we set the markers of tricuspid annulus, tricuspid septum, and the apex of the RV. Once we do this, then the next point comes is a results. This is posterior, this is anterior, and this is the RV free wall. Once we all this, the machine starts analyzing the segments. And once it starts analyzing the segment, it takes a couple of seconds. And then we can straightway go to the results of this particular phenomena. And once we click this results, can you see this? A very good depiction. Now it has come very well in this. This part is still a little bit overshot. And we can look at an end diastolic volume, end systolic volume, ejection fractions, diastolic at base dimension, diastolic at mid levels, and then TAPSE and RV free wall contraction, fractional area change is seen. And this is depicted in graphical format of all these kind of things. So this kind of a machine-based system, when we do it, it is found to be very, very useful when we analyze these people for RV evaluation on 3 dimensions echocardiography. Let me come out of this and go back to my talk.
Dr. Gupta, two minutes are left only.
I'll just finish in 2 minutes time. I'm almost done. I hope you are able to see my screen now again. Once we do this demonstrations, what is the routine clinical state of art 2019 paper correctly saying that the 3 dimensions echo has gained increased acceptance for evaluation of RV volume and function. Several studies have proved this. The only issue is when we look at an RV, large RV volumes and ejection fractions. Here is where we have utilized during this last few months in our practice. Look, one loop, ECG gating, and we were able to look at a complete RV in this COVID wards. And that's where is then potential areas, pulmonary embolism, COPD, mitral stenosis, regurgitation with RV involvement is the couple of views. And I'm sure like heart failure with preserved ejection fraction will have a significant impact. We have been pursuing a study of a COPD patients with a Patel Chest University, Delhi University, looking at this RV evaluation and their subsequent follow-up. In conclusion, I can only say this. Rapid 3D assessment and RV geometry and function is definitely an easy procedure after the invent of machine-based processor. Less time-consuming process and provide all parameters for assessment RV function and volume in one go. Some limitations are there in assessment for dilated and large RV size. Comparable to MRI, various parameters can be assessed again and again. Now the volume and EF are little underestimated as compared to MRI. Single most important utility in today's circumstances of COVID-19 with the suspicion of pulmonary embolism, however, can be useful in LV also. Thank you very much for your patience here.
It's a nice talk on RV function assessment. But in routine clinical practice, I think we should teach postgraduates as well as echo technicians to give. We should teach them more regarding RV as a routine assessment rather than only in special situations. So that is something I think we need to incorporate. Vijayalakshmi Madam, can you please go ahead and...
Excellent presentation, Dr. Rakesh Gupta. In fact, the 4D is much easier than what you demonstrated. But for the Epstein's anomaly, for the RV function, don't you think that everybody should follow this? And especially in the rheumatic heart disease where the RV dysfunction is there, the surgery outcome will be difficult. So I think it should be made as a dictum for everyone to get the RV dysfunction.
I'll add one point over here. I was talking to GE people. Now, wherever they are selling E95 or above machines, we'll be together in a platform of like Indian Academy of Echo, Cardiological Society, various societies can get together to provide one-day training program to those medical colleges where they are selling E95 machines now. That's what is like once we start teaching this kind of a technology, only then the PG and subsequently, I'm sorry to say, my teachers will start adopting this technology. Many teachers, they do not know how to do a 3D assessment. And the first, the teachers have to learn and the students will learn automatically.
100% sure.
We can conclude this session now. And the next session will be taken by Dr. Mittal, and which will be on low-grade severe mitral stenosis. Dr. Mittal, we know, is the Director, Clinical Cardiology at Medanta Medicity, Gurgaon. He has more than 30 years of experience. He has established the first heart failure clinic in the country. He's in charge of the heart failure program at Medanta. He's a past president, IAE NCR chapter, members of various societies and more than 50 publications, and investigators in various leading trials. So the chairperson for this session will be Dr. Aziz Khan, who is a senior consultant cardiologist at Nagpur. He's a recipient of Dr. Ivan Pinto Gold Medal. He has presented and published several scientific papers in national and international conferences and journals. He's a PI in various global and clinical trials. The second chairperson will be Dr. Dayasagar Rao, who is a consultant cardiologist at KIMS Hospital, Hyderabad, Telangana. He's a cardiologist of national and international repute. He's the editor of Journal of Indian College of Cardiology, special interest in clinical cardiology, and he has numerous publications in national and international journals. So over to the chairpersons for conducting this session.
Thank you, Pankaj. Dr. Dayasagar Rao is there?
You can start.
Yeah, okay. Low grade, low pressure gradient aortic stenosis is one known entity, and a lot of papers have been published and have been enumerated. However, now the research interest has been generated on low gradient, low pressure mitral stenosis, because the etiology is changing. From rheumatic, we are shifting to degenerative mitral valve disease, and to know different modalities of treatment, I think none other than Dr. Sanjay Mittal. He is going to elaborate to us on how to diagnose low gradient severe mitral stenosis, what are different modalities available, and how to treat these patients. Dr. Sanjay Mittal, can you start your presentation?
Thank you, the chairpersons. As very rightly put, we have been talking hugely around the world about low gradient severe aortic. Give me a second. Okay. I think now it will come. Is that clear now? So as I was mentioning, it's very important. The chairperson was mentioning about the fact that we are all talking about low gradient severe aortic stenosis. But today I'm going to talk about low gradient severe MS. How is it different? How should we tackle, and what are the problems down the line? So this is a classical case. You can see the mitral valve is hardly opening, severe mitral stenosis, smoke even on transthoracic echocardiogram. There's aortic valve also, which is thickened, and subvalvular apparatus almost class 4, which is almost going up to the tip of the aortic mitral valve leaflet. There is no mitral regurgitation. And this is the transesophageal echo image. Again, it's a critical aortic mitral stenosis. But when we look at the gradient were just 4.5 millimeters of mercury, and peak gradients also just 7 millimeters of mercury. However, the area, as we would expect, was coming out to be 0.8 centimeters square. The aortic valve was opening well, but there was significant amount of tricuspid regurgitation. The tricuspid valve was opening well, the annular dilatation, IVC also was dilated. The PA pressures also was not too high, just 11 millimeters of mercury. So the questions are, is this mitral stenosis moderate or severe? Obviously, the valve area is not refutable in this patient, so it has to be severe. Should the person be subjected to medical management or intervention because the gradients were not there? And what would be the outcomes after the intervention? We all know the valve area is something which has been redefined from what in 2009 ASE was given as 1.5, more than 1.5 mild, 1 to 1.5 moderate to less than 1 as severe. The mean gradient at that time also was 10 millimeters or more to be as severe, with the PA pressures of 50 millimeters or more to be severe. However, it was redefined in 2014 by ACC-AHA, where anything below 1.5 was ranked as severe, mitral valve stenosis, and less than 1 centimeter square was critical mitral stenosis, or very severe mitral stenosis. If you look at the situations where the gradients and the planimetered valve area does not match, there could be significant mitral stenosis, but with high gradients. So this matches, and this means it's a severe MS. However, sometimes the pressure half time may not conducively severe mitral stenosis, and this may be because of small LA or non-compliant left atrium or raised end diastolic pressure as in presence of AR. If, on the other hand, if we have non-significant mitral stenosis with a high gradients, this is something which is a paradox again, but in this situation, pressure half time also can be going the third way. It may show significant mitral stenosis where the valve area planimetered was not significant, and this may be because of the funnel-shaped stenosis, subvalvular mitral stenosis. And here we also, whenever there is a discrepancy in these two things, we should always recheck the planimetry at the tips. And sometimes usage of three-dimensional guided mitral valve area calculation might be good in this. The pressure half time showing non-significance, this may be it is high volume state, tachycardia, MR, anemia, thyrotoxicosis, whatever. The other thing could be low gradients with non-significant MS. This could be when the pressure half time matches or matches with the planimetered area. This means it is mild. However, if there is a mismatch, this can very commonly be seen as a residual PST defect in post-BMV situations. But this is the point of discussion today, where there is low gradient and planimetered area also is showing severe MS, mismatches there. And if the PST also is showing severe significant MS, I'll discuss out with you later, this could be a defect in the rate or the stroke volume. So we call low flow, low gradient whenever there is a valve area of less than 1.5 centimeter square, that is significant MS. But the mean gradient is also less than 10 millimeters, not higher than 10 millimeters of mercury, with a preserved transmitral flow of 35 ml or less per meter square. So decreased flow, decreased gradients, but significant mitral stenosis. That is a combination when we call it as a low flow severe MS. What could be the reasons? As the chairperson was mentioning very clearly, there is a reason for this mitral stenosis not behaving as our other mitral stenosis would behave. So there could be a reason to reduce the stroke volume, and this stroke volume reduction could be because of significant subvalvular apparatus thickening, or there could be adjacent basal myocardial involvement. If there is swelling of the subvalvular apparatus or basal myocardium, there is a restrictive physiology going on there, which can reduce the stroke volume, and that's how it can lead to decreased flow across the valve and decreased gradients. Rheumatic pancarditis also is a very common factor we should always look at in this situation. Presence of atrial fibrillation is a very common thing which reduces the gradients, mainly because of the fact if the rates are well controlled, because the atrial kick is gone, and I'll show you the reason why it should happen. Presence of pulmonary hypertension again leads to the fact that there is a pre-stenosis to mitral valve, which leads to a reduction in flow through the pulmonary circulation to the left atrium and reduces the gradients. Comorbidities such as hypertension or coronary artery disease, which increases the stiffness of the left ventricle, also would reduce the flow from the mitral through the mitral valve and cause low flow situations. The other very common thing is heart rate. If the heart rate is lesser than 70, then the gradients across the mitral valve was going to be low. This is a beautiful paper which was presented last year in 2019 in Journal of American Heart Association, which showed this particular problem. It was very common to find almost more than 50% of people were having low gradients, but despite significant mitral stenosis, which was detected in this particular paper. So it's not so uncommon. The other thing was, it was more frequently found that the people who had low gradient severe mitral stenosis are elderly. That means they have other comorbidities. they were more likely to be NYHA class 2. 30% of them were NYHA class 2 as compared to 13% if the gradients were high. So the symptoms were more correlating with the presence of low gradients or higher gradients. Atrial fibrillation was much more frequent, almost 2 times as compared to the high gradients, 58%. They were more likely to be on beta blockers, and the heart rate was lower, less than 70 beats per minute. Mean pressure gradient was lower, and area was also a little higher. This is a diagram to explain why a presence of atrial fibrillation, you have the loss of atrial kick, which would represent as this difference in the LV end diastolic and the LA pressure to go away. And so the mean pressure gradient would drop down. So the presence of atrial fibrillation for the matched heart rate would have a lesser degree of gradients. So what does the clinical implications out of this? One, as I said, it is very likely that the symptomatic improvement is going to be less because the symptomatic status more depend upon the gradients. Mitral valve gradients, best predicted value is there for the symptomatic status, as I said, and we may use stress echocardiogram to elucidate what is the exercise-induced or heart rate-driven gradients, which correlates better with the symptomatic status. In this particular study, which I was talking about, they all subjected all the patients to balloon mitral valvulotomy, and they found that after the balloon mitral valvulotomy, people who had high gradients did show better improvement in change in the LA pressures and the mean gradients across the mitral valve as compared to the low. There was a lesser degree of fall in the gradients in the mitral valve with low gradients. And also, if you look at the symptomatic improvement, there was substantially low degree of improvement in patients who had low gradients rather than those who had high gradients. That means we are, as the chairperson said, talking about some disease process other than the mitral valve disease. Also, if you look at the long-term outcome, the prognosis, these patients were followed up for 6 years. The patients who had low flow, low gradients, they had the worst outcomes, almost more than 50% mortality over the next 6 years. And the best outcomes was when there was normal flow, but still low gradients, means really lesser degree of mitral stenosis. A word about this group, which also is to be defined, normal flow, but still low gradients. The importance is that this signifies lesser severe mitral stenosis, and best do is exercise test to elucidate whether these patients are having severe MS or not. A case in here, this is mitral stenosis, but mitral valve opening is better. No significant MR or AR is seen here. The valve area was coming out to be 1.5 centimeters square. And the pressure half time was also be about 1.47 centimeters square, but the mean pressure gradient was just 6 millimeters of mercury. The flow was preserved in this particular patient. We did an exercise echo. This is the baseline, and the baseline was 6.4, but you can see after the exercise test, the gradient jumped up to 18 millimeters of mercury. The TR gradient also increased to 35 millimeters of mercury. This is after exercise. You can see the gradients have jumped up through the mitral valve to about 18 millimeters of mercury, and the TR gradients also had increased to about 49 millimeters of mercury from 35. So this unmasked the significant mitral stenosis. However, unfortunately, the data as of now is not evident in large scale studies about the utility of doing stress echocardiograms predicting severe mitral stenosis. But ladies and gentlemen, and to summarize, among patients with severe mitral stenosis, a subset definitely exists. Almost 50% of them would have low output and low transmitral gradients. Patients with low flow, low gradients, severe mitral stenosis had higher arterial afterload, greater prevalence of atrial fibrillation, more subvalvular thickening, and decreased left ventricular compliance compared to those with high gradient mitral stenosis. Patients with low flow, low gradient mitral stenosis had less symptomatic improvement after valvuloplasty. This is very important to understand. And mitral valve gradients are better predictors of symptomatic status in patients with significant mitral stenosis. Thank you.
Oh, thank you, Dr. Sanjay Mittal. I think it was a good presentation.
But I think suffice it for you to understand that the gradients, or in cardiology for that matter, the pressure is equal to flow into resistance, and resistance offered by the mitral valve. So any changes in the pressure gradients, one should look both at the mitral valve area and also the flow. So interpreting the data without knowing the flows, I think it will be a misplaced emphasis on the pressures. The exact corollary of this low gradient tight MS will be a mild MS with high gradients like what we see during pregnancy, even though there is mild MS. But as Dr. Nanda has said, the patient symptoms are related more to the LA pressure than to any other gradients. Be that as it may, I think in practice, whenever there is a discrepancy between the anatomically measured area by 3D echo of the mitral valve, and there is a discrepancy between the anatomical area and the hemodynamic criteria. We need to pause for a minute and then see what is the diastolic period, which is proportional to the heart rate and to the cardiac output as well. So if you are aware of these two things, that the LA gradients or the pressure gradients of the mitral valve is influenced by mitral valve area and the cardiac output. And probably once you consider that, you will not be making the fundamental mistakes.
I have one comment I wanted to make. Sanjay, in the Heart Association paper, Journal of the American Heart Association paper, I saw there are quite a few older patients. And once you have older patients, then one compounding factor is the severity of mitral annular calcification. So, that adds to the conundrum here. So that is also very important. I think when you think in terms of the younger patients, you're not worried, but once the older patients, then that creates a problem also.
In the elderly patients, there is one more variable that comes into the equation, that is the diastolic dysfunction of the ventricle as we old, and that also interferes with your hemodynamic measurements of mitral valve severity. I think age of the patient, as you correctly said, is an important variable, but I think MAC probably is underestimated.
Also, I think these patients with mitral annular calcification, it has been shown very clearly mitral stenosis produced by annular calcification severity. Those patients, the gradients don't actually correlate with the severity of mitral stenosis. So that is another way to look at it. And then I think you calculate on the basis of flow going through the mitral valve, but not just on the basis of gradient. That has been shown also. I mean, that's much more of a problem in United States, having mitral stenosis on the basis of annular calcification than rheumatic, Okay.
I have one comment, Dr. Mittal, that this from Chennai, Dr. Asha Murthy. Patients who are undergoing coronary artery bypass surgery and they have an association of severe mitral stenosis is underestimated, because we found that they undergo a bypass surgery but without touching the mitral valve. But when they come for the follow-up in your review post-operative period, we find that the mitral stenosis is severe. And then this patient has to undergo a intervention accordingly, whether it is LV clot, LA clot is there present or not. I just wanted to have your comment from you.
Absolutely right. And if you focused on the slide which I was showing out, the reasons for low gradient severe MS, ventricular pathology is very important, and coronary artery disease as well as hypertension both lead to reduced flow through the mitral valve and can underestimate the gradients and fool us. That's very valid point.
Thank you, sir.
I think there's one question in the chat box. Dr. Nihal is asking how to know the correct gradient in low gradient MS. How to know the exact gradient?
So what we do is exactly what I tried to show you. If a person is having symptoms and the person is having low gradients and valve area is coming out to be significant by planimetry, we do subject them to an exercise test. Increase the heart rate to about 100 beats per minute and see what the gradients are going to be. And more often than not, if they cross 18, this means his symptom level is at 18 millimeters of mercury, and this person should be handled.
Okay.
Dr. Mittal, I have one question.
Yes.
In the LA area or volume, which one is higher in low flow or high flow MS, severe MS?
So as is very evident, if you have a bagpipe situation, bagpipers, they have a large bag. If the LA is large, the pressure generated during the atrial systole is going to be low. And it's likely that larger LA is also going to be associated with atrial fibrillation. So a lot of comorbidities. One, the compliance of the LA is higher. Second, this more likely to be in atrial fibrillation. And third, the atrial kick is likely to be underestimated. So they are likely to have low gradients.
Dr. Mittal, would you like to give a the Doppler parameter of the flow through the mitral wall?
The Doppler parameters of flow through the mitral valve?
Yeah, because gradients are dependent upon the flows.
Absolutely. So we have to realize that the forward flow through the mitral valve is only in diastole. So we are just focused on the diastolic flow, forward flow, which can be taken and then estimated at the annular level. If you have to look at the forward flow through the mitral valve, you have to look at the mitral annular level and take the mitral annulus and calculate the annular area. If you take the mitral valve area, which is stenosed, this may be a wrong prediction because of the fact that it's a geometrically deformed valve, and sometimes you may make minute errors in the estimation of the area, and that can be a problem. So what I usually do is we calculate the stroke volume or forward flow through the mitral valve, looking at the annulus.
I think with this, we conclude this session now. And I congratulate Dr. Mittal for a wonderful explaining the low-grade severe mitral stenosis. Now, the next topic is also very interesting: when to intervene in asymptomatic aortic regurgitation. To talk upon this, we have again Dr. Rakesh Gupta, and he'll be speaking on this topic. And the chairperson for this session will be Dr. Satish Shurivanshi. So Dr. Satish is a director and senior consultant at SMC Heart Institute, Raipur. He has more than 20 years of experience in cardiology in Chhattisgarh. He has many publications in national and international journals, and he's a pioneer of CSI, founder society of CSI Chhattisgarh chapter. Over to Dr. Satish for conducting this session. You need to unmute yourself, Dr. Satish. Dr. Satish, you need to unmute yourself first. Yeah.
Good morning, all.
Yeah.
And this is a very next topic is very interesting, and a very eminent speaker, Dr. Rakesh Gupta. We all know about him. He's a very well-known figure in the field of echocardiography, and I will say master, so he will be there. So very important topic he will be discussing about. Lot of time in the practice we come across a patient who is a young patient who is having a severe aortic regurgitation, but he is asymptomatic. So the real dilemma comes here whether this patient should be operated, because what we see that the perioperative mortality is about 4%. And when these patients, they are followed up for a long time, and so the morbidity and the mortality because of the AR is less than 1%. And again, once the patient is having a prosthetic mitral wall, aortic wall, you have the side effects of the drug, bleeding issues, and not managing the INR properly in India especially because of the financial issues, rural areas. So this topic is very important. We have to discuss what is the real genuine patient of severe aortic regurgitation who will be benefited by getting surgery with more benefit than a long-term follow-up. So I request Dr. Rakesh Gupta to start his talk.
Yeah, I'm starting. Thank you very much for allowing me to talk on this aortic regurgitations. Is a very important topic for day-to-day practice. Let's say what is the management of asymptomatic severe aortic regurgitations. Let's start with the case presentation. Here is a patient who has got an almost high normal LV, normal LA, and if you can see, there's amount to be significant aortic regurgitations. And many people will say at this moment, possibly it's about a true severe aortic regurgitation. When we look at an LV size, the indexed LV size, if you look at the indexed LV size, and absolute values are 66, diastolic and end-diastolic values are 44. And this patient has got a borderline increased systolic flow of 2.71 meters per second. LV function is almost normal. And when we look at a holodiastolic reversal of flow in descending aorta, we have got a significant holodiastolic flow in descending aorta with an VTI of 22 and end-diastolic velocity of almost 20 centimeters per second. The dimensions are 66 and 44, and we transform these dimensions to 33 and 22 millimeter of index values. Severe aortic regurg with vena contracta of 0.7 centimeters or more. Normal LV systolic function, which was 58%, and a holodiastolic reversal of flow in descending aorta. If you look at this particular patient, if he's asymptomatic, what the guideline says? Guideline says in American College of Cardiology or American Heart Association or European Society of Cardiology, the class 1 indication in asymptomatic is when LV ejection fraction is less than 50%. Or if the patient is undergoing other cardiac surgery at the same time, we must replace the aortic valve. And if you look at this guidelines, which was published in 2014 in American College of Cardiology, asymptomatic, other cardiac surgery, ejection fraction more than 50%, and systolic dimensions of more than 50%, class 2A. And if you look at the class 2B indication is more than 65 and more than 50% of ejection fraction. That was something like in class 2B. What was the problem with us? We had a dilated LV with an index value of 44. That's 33 and 24. It classifies into periodic monitoring. If you look at all we saw in our patient. Let's see whether these guidelines are godly lines, or they are godly lines. Modify these guidelines according to circumstances. And these guidelines, they were formulated in 2014, subsequently in 2017 by European Society of Cardiology. And we are in 2020. That's a coronavirus year, I always say. And this coronavirus has changed many things over a period of time. And maybe in 2021, we'll be somewhere else. So whatever the guidelines are present as of today, are they really true? Maybe not. And that's what the important thing I would like to say by showing a couple of papers in this particular scenario. Let's look at the decision-making asymptomatic aortic regurgitation in the era of guidelines, incremental value of resting and exercise cardiac dysfunction. Look at this paper, very categorically says that comprehensive resting and exercise echo was performed in 160 patients. If the end-diastolic dimensions are less than 70 and end-systolic dimension less than 50 or less than 25, in whom the initial management was expected, as was in our patient, was let's subject these patients for LV strain at rest and after exercise, RV strain at rest and exercise stops it. When these patients were subjected to strain evaluation at rest as well as after exercise, this is a graph where the people had resting LV dysfunction, which was not there. This is the people who had developed an LV dysfunction after stress, that is by strain imaging. And these are the paper when we looked at these subjects when they had LV dysfunction by strain imaging present at the onset only at the time of resting and subsequently stress. Same was true when these patients were looked at RV strain evaluation at rest. It was not there, exercises was not there. The significant surgery-free survival, and this included all patients except those who underwent surgery at 3 months interval. When including all these people, including those who underwent surgery, the people who did not have LV dysfunction before and after stress, they did much better than the people who had whether after stress or at resting period. Similarly, RV strain, if the RV strain was present at the resting period or developed after exercise, they did very poorly in this subset of population. So concluding says that the evaluation of resting and exercise RV function as well as LV function in the assessment of timing of surgery in asymptomatic patient is significantly useful and should be done in every subject coming back for aortic regurgitation evaluation. Another paper incremental prognostic utility of left ventricular global stain in asymptomatic patient with significant AR with preserved ejection fraction. Here is a one patient who has got an absolutely normal GLS of LV. Here is a one patient who has a significantly reduced GLS of LV at resting period. Now their ejection fraction is normal. And what they consider ejection fraction normal as more than 50%. And look at this graph of this patient. These were the people who had a GLS of more than 19.5 versus GLS of people of less than 19.5. Saying that if you have a GLS, resting GLS in a normal ejection fraction less than 19.5 of median value, it means these are the people who are at a high risk and they should be subjected for surgery. And same thing was said, the people who underwent surgery, the freedom for death who had a good GLS versus who had a poor GLS. If you're saying all this, the category says that a person should be evaluated for LV-GLS. Poor the LV-GLS, the high chances of mortality in the subset of population. This is the fallback of the same paper which was showed a couple of minutes back. Long-term outcome after aortic valve surgery in patients with asymptomatic chronic aortic regurgitation with previous preserved LV systolic function. And let's see the impact of baseline and follow-up of GLS of these people. When these people were followed over a period of time, the people who had a good baseline GLS, they did much better than the people who had a poor GLS. In fact, saying that if you do not subject these people to surgery, when they have a poor GLS, the outcome is pretty bad. And that's what he wanted to say in this particular paper. Then came the staining of new prognostic predictor of asymptomatic severe aortic regurgitation. This was editorial. It said that in compensated stage, patient with severe AR remains asymptomatic for years. The onset of symptom represent a key development since the symptom presence is well-known predictor for adverse outcome. In many patients with severe AR may not recognize the slowly and insidious progressive symptoms and may deny them for adopt a sedentary lifestyle. And what it says that in so-called asymptomatic patient with equivocal symptom, a standard exercise test is helpful to confirm or disapprove the presence of symptoms of daily life, saying that these people should be subjected to stress tests to evaluate both their LV stain as well as their RV stain, look at the exercise test, TAPSE, and unearth the symptomatology of these people. Just published a few days back, Association of Echocardiography Left Ventricular End-Diastolic Volume and Volume-Derived Ejection Fraction with the outcome of asymptomatic chronic aortic regurgitation. Paper category says that end-systolic volume indexed and volume-based ejection fraction, they worked as well as end-systolic dimension index and linear ejection fraction in discriminating risk of access mortality. And what did they say? We should modify the ejection fraction to less than 60%, end systolic dimensions to 21 to 22 millimeter, end systolic volume index to 40 to 45 ml. And if I conclude all this, we need to modify a guideline, change the ejection fraction to less than 50, less than 60 instead of 50, change the threshold of end-diastolic volume and stroke volume to 21 and 22, the end systolic dimension index and end systolic volume index to 40 to 45, reduce GLS minus 19.5, reduce GLS of RV minus 20, and exercise TAPSE if it falls to less than 9.5. And that's what was present. And if you look at the subject of our population, which looked at the subject of ours, 58% was our ejection fraction, that was more than 50%. LV dimensions were 33 and 22, and you look at 33 and 22 with this value. And when we compared the GLS of our patient, the GLS of our patient was, global GLS was 14.5 and RV GLS was 17.7, the same patient. And when we compared our patient and subjected to GLS of 14.5, RV GLS of 17.
Dr. Rakesh Gupta, 2 minutes left.
TAPSE as 9 centimeters. Our patient was very well fitting with the patient who was subjected for aortic regurgitation surgery. Though he does not belong to the guidelines as has been prescribed previously in American Heart Association and American College of Cardiology. So our patient, whatever he showed in the beginning, was ready for surgery. It's not the guidelines, it's the godly lines which are playing a lot of impact in today's management of asymptomatic aortic regurgitation subjects. Thank you very much.
Dr. Satish, you need to unmute yourself. Dr. Suryavanshi, you need to unmute yourself.
Guidelines, they are there, but the guidelines, they change year by year, and you have new guidelines by ACCHA. Yeah. So, like you already talked, we already had a role of exercise in asymptomatic aortic stenosis. Now you are saying that the role of exercise is there, LV strain, RV strain, and then TAPSI. So this was so these new things have come, and maybe in the future, new guidelines which they come. And once we have data from the trials following, and the patients are followed for a long period using these new criteria which you had shown. Definitely we will have new guidelines, and these patients will be subjected to earlier surgery, because we know that once these patients, they become symptomatic, the prognosis is very, very poor. And once they develop a LV dysfunction and dilated LV, more dimensions, definitely the outcome is worse. One of the different subset according to the guidelines, which I think is female patients and underweight patients, where we cannot use the old guidelines also of the end diastolic volume and systolic volume and the ejection fraction. What is your take on this, Dr. Rakesh Gupta?
I say always, whenever we look at these patients, what we are doing in our lab is we're always taking indexed values.
Yeah.
Looking at the absolute values. Even if you say that whenever I took up measurements, I'm always converting them on body surface area measurement.
Yeah, that is important. Most of the
very important parameters, because that is need to be taken into consideration. And over a period of any valvular involvement, we are subjecting more to indexed value rather than absolute values.
Thank you, Dr. Gupta. So now I think we have a message and other questions from other.
There's one more question.
Other questions?
What is the role of cardiac MRI in assessing asymptomatic severe AR for surgery? Role of any CMR, cardiac MRI?
I'm sorry, like I don't have an answer. Maybe a couple of colleagues sitting over here, they are good enough in talk to about this. They may come up and may answer this. I'm really sorry about that.
So after this talk, I think we have something new. And once the patient will come to us with a severe asymptomatic AR, now we will be doing LV strain, RV strain, and TAPSI also in all the patients.
We are doing as of today. We are doing in our labs.
But we see all people, those who are doing, and the patient who comes to assessment. Because at peripheral places, I think people are not doing it. So a message very important goes from this talk that we have to use it in our practice.
Okay. Thank you, Dr. Rakesh Gupta, for excellent deliberation on asymptomatic AR. Now, in the next session, I'll be conducting, it's a quiz session. I have a set of around 10 echo films, and I'll present one by one, and anybody can comment. The audience can comment through the chat box, and the faculty can comment directly.
ये मेरा screen हटा दो.
Okay. So are the slide visible now?
Yes, yes.
Okay. So the faculty can comment at any time, and the delegates can comment through the chat box if they want to give any answer. Now, what is this sign known as? This is a patient presented with shortness of breath and hypotension, sudden onset. What is this sign known as?
Paradox.
McConnell sign?
Yeah, exactly. This is a McConnell sign. We know that McConnell sign is a hypokinesia of the RV free wall and selective sparing of the RV apex. Means RV apical contractility is normal, but the free wall is hypokinetic. And this is very much seen in patients with pulmonary embolism. And the theory behind this is, they say because of the RV is hypocontractile, whereas LV apex is hypercontractile. So there's the illusion that it tethers the RV apex. So it appears that RV contractile is normal. The second theory is there's selective ischemia of the RV free wall, not at the apex. And third is the RV shape becomes elliptical. So the spherical. So the spherical space exposed to the more contractility of the RV apex. Anyhow, This patient was thrombolized, and you can see the improvement, and the mecanal sign has disappeared almost, and the RV contractility has become the normal. So this is the mecanal sign we all should remember, which is seen specifically mainly in pulmonary embolism, but can also be seen sometimes in RVMI also.
It is important to remember mecanal sign is not infrequently seen in inferior wall MIs.
Okay.
With RV involvement, with RV infarction. So there are mistakes have been committed because since mecanal sign was there, everything else was ignored, and then you should not pursue only PTE.
Yeah. Yeah.
Okay.
Yeah. Your point. Yeah. Very correct, sir. Agree to it.
Yeah.
Any more comments, or should I?
Dr. Pankaj?
Yeah.
What about in cor pulmonale with severe pulmonary hypertension? Because in that also the RV is dilated, but we don't see this.
But you don't see selective sparing of the RV apical contractility in the insert. It is very specific for pulmonary embolism and also with RVMI in the presence of inferior MI, as pointed by Dr. Dayasagar Rao. Okay.
Right.
I think the pulmonary embolism has increased in the corona scenario.
Yes.
People should start looking for this sign.
Yeah, that's. Yeah, agree. Now, the second is, now what is this abnormal flow seen in the right atrium? You can see there's some turbulent flow seen in the right atrium. From where this flow is generating, and what is this turbulent flow in the right atrium?
I think
this patient has undergone a surgery recently.
Pankaj, could it be this partial anomalous pulmonary vein drainage?
No. This is in the right atrium. You can see. Yeah. No, it's not the correct answer.
No.
Basically, this abnormal flow is generating from, there's some SVC obstruction. There's a compression of the superior vena cava. And the reason for compression was this, there was a retroatrial hematoma after the AVR, which was done in this patient. So that retroatrial hematoma was compressing the SVC, and this is the SVC flow. You can see the turbulence because SVC was compressed externally by that hematoma, which is giving this turbulent flow. So this
patient is in superior vena cava only.
Yeah.
Because of the turbulence, we have to look for the obstruction.
Yeah, exactly.
Exterior or interior?
Yeah. So this
Actually,
was
it is worth remembering that in patients with SVC type of ASDs, when they are repaired, there's a very high frequency of obstruction to the SVC. If the surgeon is not very careful, he can create an obstruction. We have seen quite a few of those. This is specific to the SVC type of ASD.
Yes, sir. Point well taken.
Okay.
Yeah.
Okay. Now, the third is, this is a 4-chamber view. 2 small balls are visible on the atrial roofs. Is it a normal finding? Is it a tumor, thrombus, vegetation, or a normal finding, or an artifact?
I think it could be, sir. Can I speak, sir, Dr.
Yeah,
Pankaj?
anybody can speak.
Yeah, this looks like it's more of an artifact, I think. The RA, the atrial chambers are foreshortened, and you're only seeing the roof.
But if you look at the echogenicity of that structure, it's almost similar to the tissues. Artifact will have some different echogenicity. If you can see, it matches with the surrounding areas, the endothelium.
Could be hypertrophy in the pectinate muscle of the atria itself.
Yeah, it has to do something with the embryonic development of the atrias. This is basically on the right side, we call it the crista terminalis. Yeah, exactly. The answer is correct. On the LA left side, it is called as, excellent. The left side is a LA Commodorean ridge. On the right side, we call it the crista terminalis. I think these are just embryonic remittents. Yeah, exactly. A round of applause to Dr. Prashant. These are just embryonic remnants of the atria. On the right side, we call it crista terminalis, and the left side is the LA Commodorean ridge. he can get confused with whether it's a tumor or something to do with the thrombus also. But if you look at the echogenicity, it is almost in parallel with the surrounding structures. And also the mobility is not independent. So had it been a thrombus or any other thing, that mobility should be independent of the surrounding structures. And also there's no substrate for thrombus. So this cannot be a thrombus. This was basically a...
the warfarin ridge is a normal structure. It is not,
it is a normal structure, yes.
And in the past, people were mistaking it for the thrombus and putting on the heparin. And that's why they're called as anticoagulants. So the name is thymidine ridge or warfarin ridge.
Yeah, exactly. Exactly. So very, very valid points.
I will show the cases of vegetation.
Okay. Yeah, you have a complete talk on masculating of vegetations. Yeah. Now the fourth is, what is this? Is it a tumor again? Thrombus?
Pankaj, hydrated cyst.
Yes, yes. Yeah, it is. This is a very classical of hydrated cyst.
You can see that multiple.
Yeah, hydrated. It is basically hydrated cyst only, and we know that hydrated cyst is extremely rare, more common in liver and lungs. Heart is rare to get affected by this. Among the heart, left ventricle is the most common site. They are usually subepicardially located, hence they rarely rupture into the pericardium. But the main complication is cystic perforation and septic embolization. And the treatment is usually surgery first, followed by chemotherapy. So answer is correct. It's cardiac hydrosis or hydrosis of the heart.
Pericardium also.
Yeah.
Pericardium and the lungs.
Yeah.
Pericardium.
Yeah, pericardium also. But left ventricle is the most common site among the heart. Okay. Now again a very interesting echo. This is one study going on. This patient presented with retrosternal chest pain, and this operator is doing there's a funny air bubble test.
Contrastic.
Air bubble test by drinking the carbonated air drinks like any soft drink, which is a aerosol.
This is hiatus hernia.
Dr. Nanda.
Yeah. Doctor, I think,
Yeah,
Dr. Deyasagar, I was speaking, I suppose.
Yeah.
This is a very wonderful demonstration of the hiatus hernia by drinking the ginger LA or any carbonated drink. You can see the structure behind the LA is completely opacified by the drink. And this is hiatus hernia, which can present as a small outpouching of the stomach through the diaphragm and can present as a space occupying lesion just behind the left atrium, which can be confused with other region. But by doing simple air bubble test, you can demonstrate this hiatus hernia. Yeah, Dr. Gaurav.
Patient, I known cardiac surgeons opening it up, thinking it is a mass, only to realize that it was a hiatus hernia.
Yeah, very good. Yeah, it was hiatus hernia only.
Yeah.
Now again, what do you see in the left atrium? Again, is it a thrombus, myxoma, artifact, or extrinsic compression of LA, or what is it?
Extrinsic compression.
Yeah.
Looks like Pankaj.
Yeah.
It looks like extrinsic compression of LA.
Yeah, Dr.
And the mitral valve also.
Yeah. Achha, Dr. No, it is not. The appearance is not at all like hydrated. First, it is within LA or is outside LA? We need to first.
It's outside LA.
Yeah, it is looking more of outside LA.
LA.
Compressing. Yeah, answer is very correct. There is an extensive compression of LA. There was a huge bronchial cyst, basically.
I have seen bronchial.
CT scan was done. There's a huge bronchial cyst, which was, it was a mass compression only because of large bronchial cyst compressing the left atrium from outside, as was seen in the CT scan was done, which confirmed the diagnosis. This was the X-ray of that patient. So the correct answer is, they are correct. Everybody is correct. Those who are saying extrinsic compression, the correct answer is extrinsic compression of left atrium by a bronchogenic cyst. Yeah. Correct answer. Yeah. Now this gentleman presented with a recent onset of acute myocardial infarction. He had an acute MI. And this is an echo done after 2 to 3 days.
Mobile
What do you see there?
Mobile thrombus, which is partially organized. The layer.
Okay, maybe, or something else. I think it's
dissection.
Thrombus is usually, it is more attached to the IUC, IVS. It is not at the apex. Thrombus is more common in the LV apex.
No, this is a serpiginous VSD.
Dissection of the myocardium.
Yeah. This is basically dissecting hematoma of the intraventricular septum. I think it is open to discussion, but the diagnosis which we have made and which we have discussed with others also, this is a dissecting hematoma of the IVS, which can be seen after an acute myocardial infarction or after a infective endocarditis or after any surgery. You can see sometimes congenital also. So the diagnosis which was made in this patient was dissecting hematoma of the intraventricular septum. This may mimic thrombus, but thrombus is more common in the LV apex. But this is seen more in the attached to the IVS.
IVS. This is IVS.
So
I think
clinically, was there a murmur? Clinically?
No, there was no murmur. It was an acute myocardial infarction patient only. There was no audible murmur.
Murmur won't be there.
There was no VSD as such.
Yeah, that's what I said.
Yeah.
Sometimes a serpiginous VSD.
VSDs. Yeah.
But Dr.
That is the
Pankaj,
entry
we
point
have
is
the color flow also. So that
Pardon?
if we roll out serpiginous VSD also.
Yes.
It should show the consequently the color flow also.
Okay. Right. I don't have right now this.
That's
color.
okay, no problem.
Yeah.
But to clarify that picture.
Yeah. But have you others have seen such dissecting hematoma in your clinical practice? Because this was the first case I have seen in my.
Yeah, Pankaj, congratulations. Next time with the color Doppler.
Yeah. Okay. Okay.
Echo. You will get an excellent picture.
Okay. Okay.
Fine.
So the diagnosis was dissecting hematoma of the IVS. Now again, what is this sign and in which condition do you see this sign? Now, if you try to notice, you see a cyclic, something is happening. There's a band of echogenicities coming and going, disappearing with posterior dropout. There's in the anterior part of the heart, you can see in systole, there's some echogenicities coming and is dropping out and is vanishing in diastole.
Maybe a flap that is moving.
Flap? No. You see a band of echoes coming in systole in the anterior part and is disappearing in the diastole in a cyclic manner.
Maybe it is aortic wall, prosthetic aortic wall.
No, it's not.
Yeah.
This is what we call as an air gap sign, which is seen in pneumopericardium. You see in systole, once the cardiac size reduces, the air is pushing inside the heart, in the pericardium, and is displacing everything. And in diastole, when the cardiac size increases, the air is displaced. You see the cardiac chambers. In systole, you are not able to see because air is coming into the pericardium, because in systole, the heart size reduces. So the air is taken. This is what we call a cyclic air gap sign, and which is very classical of pneumopericardium, air gap sign. The cyclic, pneumopericardium or, it's correct. It is air gap sign seen in pneumopericardium. And this gentleman has a bronchoscopy done in emergency, which led to the perforation of the bronchus and air leaked into the pericardium. This is air gap sign. Now again, a very interesting echo. This was a postpartum lady, 36-year-old female, who had admitted with severe chest pain. Postpartum lady, severe chest pain, and this is an echo.
Pankaj, dissection of aorta, ascending aorta.
Yeah, this is
dissection of aorta
dissection
type
of.
A. BK,
Yeah.
That is DPK's classification A.
Yeah, this was a
In
case of
which it involves only the ascending aorta.
Yeah, and another important point in this patient was she had a family history of similar problem, and she had a Marfan syndrome also. And we know that in Marfan syndrome is one of the risk factor for dissecting of aorta, and also this had postpartum case, and any postpartum, any pregnancy also can lead to thickening of the media, and which can lead to dissection particularly in the presence of Marfan syndrome. So this was the case of, you can, in this very beautiful pictures, you can see
with the Marfan syndrome, the incidence becomes higher.
Yeah.
And more precipitating factor
Yeah.
is pregnancy.
Yeah, you can see the flap, the true lumen, the false lumen is visible in the short axis view also. The video is not moving, I don't know, but this was a case of this Marfan syndrome. The CT was done, which confirmed the diagnosis, and you what with the classification, your DBKC classification, this is a type 1 because it involves the ascending aorta as well as the descending aorta. Had it been limited to descending aorta, it's a type 3. And then the clinical implication of this classification is if this type 3 means sparing of the ascending or the root, that it can be managed conservatively. But if the aorta, ascending aorta root is involved, it has to be dealt surgically.
So
Again,
if then it is associated with the severe AR, or you see a hematoma in pericardium, because the ascending aorta dissection can give rise to pericardial cardiac tamponade and severe AR also.
Yeah, agree to that. Now this is the last, there's a spot diagnosis. This disease is prevalent in southern part of India.
Yeah, it's a cardiac EMF, endomyocardial fibrosis.
Yeah, this is typical obliteration of the LV apex, you can see.
But
apex.
LA and RA will be dilated. Atria should be dilated.
Yeah, atria should be dilated, but this is classical of. It is more common in the RV, but LV can also be involved. Here you can see LV is more than RV here, but commonly we see RV more than LV. But still, this is endomyocardial fibrosis. You see apical fibrosis RV or left ventricle. There's a tethering of the AV valves. Giant atrial enlargement is not seen in this case, but usually atrias are enlarged and there's a restrictive filling on Doppler, and apical thrombus may be associated in this. And this is more common in the tropical country and more in the Kerala and southern part of the India.
Dr. Pankaj,
yeah,
this endomyocardial fibrosis was a thesis in when I was doing my DM cardiology at Sri Chitra Tirunala Institute of Medical Sciences in Trivandrum. So it's more commonly it is seen in RV.
Yeah, correct.
In which there is an obliteration of the inflow.
Yeah.
The outflow may be dilated, but the atrias are not dilated like in mitral stenosis.
Okay.
But the similar picture, it's just like simulates like a rheumatic heart disease, mitral stenosis, tricuspid stenosis. But overall, you see the murmur very short duration, systolic murmur, mid-diastolic murmur.
Yeah, and the pathognomic is you see the obliteration of the LV apex, almost fibrosis. LV apex almost obliterated by this fibrosis. I think this is the last
diagnosis will be amyloidosis, sarcoidosis. We have to differentiate from these structure.
Okay, I think with this I finish my quiz and thank everybody for our active participation.
Yeah, I thank Dr. Pankaj for showing very interesting echoes.
Thank you. Echoes. Thank you.
It has enlightened our knowledge.
Thank you. Thank you. Now, with this, we move on to the next session, which will be taken by Dr. Vijayalakshmi. Dr. Vijayalakshmi is a professor of cardiology at Bengaluru Medical College and PSSMY Multi-Specialty Hospital, Bengaluru. He started the first pediatric cardiology department in Karnataka in 1998. He's a pioneer in intervention in pediatric cardiology. For the 3 decades, he has been teaching a lot of students. He has a brilliant academic year. She's the author of Monogram on Acute Rheumatic Fever and Rheumatic Heart Disease and Step-by-Step Echo and Congenital Heart Disease. He's editor of textbook A Comprehensive Approach to Congenital Heart Disease. She has published Vijaya's Echo Criteria for Diagnosis of Acute Rheumatic Carditis. She has received several awards like Raj Jyotsna Award 2008, Lifetime Achievement Award for Preventive Cardiology. He's honored doctorates of science by Karnataka State Women University. And she'll be speaking on masqueraders of vegetations. And the chairperson for this session will be Dr. S.K. Parashar, who's a former additional director, CGHS Bhopal, former senior consultant at CRPF Hospital Bhopal, former senior faculty at RKDF Medical College, and fellow of Cardiology Society of India. And the second chairperson will be Dr. Spandan Bhaduri. He's a life member of CSI API. His area of interest is non-invasive cardiology. He regularly delivers lectures in CSI and API. And he has contributed chapters in API and CSI textbook. In West Bengal Medical Education Service, he has provided for more than 2 decades. Over to chairpersons for conducting this session on masquerading of vegetations.
Are you able to see my screen, Pankaj?
Yeah, we are able to see your screen.
Yes.
Yeah.
So After beautiful deliberations from Dr. PC Manoria, and we have already he has shown these warfarin ridges and coumarin ridges in LA and RA respectively. Now, after excellent introduction of Professor I.B. Vijayalakshmi, I would like to request Professor Vijayalakshmi to deliver her lecture on masqueraders of vegetations.
Good afternoon, everybody. I think there are two things difficult in this world. One is doing the Kailas Parvata Parikrama, and the second one is speaking after Pankaj showing the quiz. So anyway, I have done the first one, second one I don't know how I'll do. It is, you all know the infective endocarditis is the vegetation forms the platelet, fibrin, inflammatory cells, and with the microorganisms, and you can have of any shape and size. This is just a 3-day-old baby which was very sick in septicemic shock, and look at the leg, how it was edematous, and then I didn't know what it was. And when we did the echo, there was a big mass in the IVC and the RA junction. So I thought it was a thrombus. And this is the Coumadin ridge, which was enhanced. And then when we did the apical fourth chamber, there was a mass attached to the intraatrial septum. So this turned out to be vegetation on all the 4 valves, including the Coumadin ridge, and then we treated with the higher antibiotics, and the child made a complete recovery. So this is a 1-month-old baby with a history of fever, chest retraction, feeding difficulty. And when you look at the echo, anybody would think that it is a mass, like a myxoma. But when you look very keenly, it is not attached to the intraatrial septum. Instead, it is attached to the tricuspid valve. So the right-sided vegetation, especially on the tricuspid valve, is more seen in the drug addicts. This was 1-month baby. So we thought it is maybe because of the intervention that the child had a stormy neonatal period and was treated in the NICU with using the umbilical vein, and that the candida was grown, and then this was a fungal ball which was almost looking like a myxoma. So this is a 3-year-old child referred for the fitness for general surgery. And then the child looked very sick and had a low-grade fever, which was missed by nurse and everyone. And otherwise it appeared normal except for a mild aortic regurgitation. And because of aortic regurgitation, when I looked, there was a bicuspid aortic valve with a mild AR. And look at the arch. There are multiple mobile vegetation in the arch. The arch vegetations are extremely rare, and you can see that these are mobile, and right from the ascending to the arch, the multiple vegetations are seen. So this happens whenever there is a bicuspid aortic valve and the SV prophylaxis is not taken care of in our country. This is a 5-year-old child who was treated for 1.5 months bronchopneumonia. When the child became very serious, the patient was referred to me. So it was a short murmur, and the patient, the small VS not explain why the child has got a congestive cardiac failure. There was a vegetation sitting on the VST trying to close it, and even then the congestive cardiac failure is because of the huge vegetation, almost like a bunch of valve causing the TS and the TR. And because of this TS-TR, there was a congestive cardiac failure, and because of the vegetation embolized into the lungs, the patient had a lung abscesses and also had a pyopericardium, and the pyopericardium with the fibrous bands was there. So pyopericardium, vegetations, and lung abscess, and all were causing the problem. So ultimately, despite the best of our treatment, we could not save this child, and hence making early diagnosis is very important. And you can see that SEC is there in the IVC, and the vegetation is also seen in the IVC, and this is how the right-sided infective endocarditis are extremely rare. Uncontrolled septicemia, more than fever of more than 3 weeks, you must suspect, and then echo is the best thing to make the diagnosis. This is a 9-year-old child who had history of fever, and the S1 was muffled, PT was very loud, and it was a known case of VST, and the child had central cyanosis and clubbing. And when we did the echo, I was totally taken aback. I didn't know what it was. Can anyone make out what exactly is this? And when I did the puncture for the pericardial synthesis, when I took the needle, in fact, I had to inject the dye to make out whether I'm there in the pericardium. Then I just got half ml of turbid fluid, and then after getting the fluid, we injected the streptokinase into this, and then we got 450 ml of almost like a dark colored fluid, because the thrombus were all taken away. And to my utter surprise, once the pericardial fluid or pus was removed and the lavage was done, there was vegetation on all the 4 valves, especially the pulmonary valve, and there was a perforation at the pulmonary valve. You can see that eccentric pulmonary revegetation jet seen due to the perforation of the pulmonary valve, and there was vegetation in all the 4 valves. And then what looked like masquerading of the whole of the heart, the child made a complete recovery. This was treated with the tigecycline, and then the patient made a good recovery. So this was the case of Garbudo shunt, because it was a small 3 millimeter, it was left, and unfortunately the highly mobile vegetation embolized and the child died. And this taught me a lesson, and later on I closed all these Garbudo shunts, however small they are, with the area 2, and literally preventing the vegetation embolization. This is the patient with the embolization. You can see that systemic embolization causing gangrene, and you can see how while the vegetation is there in the LV, any moment this can go. So for measuring the size as well as the mobility of the vegetation is extremely important, and unless we see how mobile it is, we cannot decide. So this is a 7-year-old patient presented with history of fall, and then came with the fever, and you can see that the vegetation is moving up and down. So this is attached to the aortic valve, and also the other valves were there. And what is more interesting is, apart from the vegetation in the LV as well as the mitral valve, you can see something speckled appearance in the pericardium. And that speckled appearance or the movement is because of the pyopericardium. So pyopericardium occurring in a case of ductal endocarditis is rare, but through the lymphatic it can spread to the pericardium, or pyopericardium patient can have vegetation. So vice versa, both can occur in a given person. So you can clearly see how this is the pus which is around, and the speckled appearance is because of the pus. So the patient for emergency pericardial synthesis and treatment was given. So here you must remember that infective endocarditis usually damages the valves, but pericardium also can be involved, and the normal valves also can be damaged with the Staphylococcus aureus. So hence, even without underlying disease, a person can have ductal endocarditis. So patient operated elsewhere for the pathology of fallow, and after the surgery, the patient came with the florid congestive cardiac failure, total edema, and then you can see that normally aortic regurgitation is into the LV, but here the aortic regurgitation is occurring into the RV, and congestive cardiac failure usually does not occur in pathology of fallow, whether operated or before. And this became worse after the treatment. Huge vegetations occurred on the patch that was given for the taking the aorta into the ventricle, and ultimately, despite the treatment, this child died, the 10-year-old child, because of the bacterial endocarditis. Hence, the echo and the bacterial endocarditis, it should be suspected when there is a the fever going on in these patients. So this is a 28-year-old pregnant lady, no case of heart disease, and then she had fever for only 15 days, and I was shocked to see. And as the cystic masses are seen here, and I didn't know what exactly it was, but then interventricular septum and There were multiple cystic masses, and I have never seen anything like this before. Just bacterial endocarditis cases, they can have multiple abscesses, and the mortality is extremely high. And this patient, we cannot save her. And hence, multiple abscesses around the IVC and around the aorta, all part of the bacterial endocarditis are saved. Unfortunately, we could not save her. So the vegetation occurring on the aortic valve, sometimes it mimics the fibroelastoma, but in the CTAT, the vegetations that you see here are attached to the valve and then they are mobile. And whatever you see in the 3D, 4D echo, the same thing can be seen in the postmortem or after the surgery. The thymus and the thrombus and the vegetations are very difficult to distinguish despite the 4D echo or whatever it is, and we have to take a clinical trial of fever, pallor and clubbing should be looked for. So any anomalies that we can see, the vegetations can be single or they can be multiple, they can be involved into multiple valve leaflets and extension to the extravalvular structures. And I have seen in the patients where the palpitations, the caudal tear, aneurysms, abscess, fistula, all can occur with the bacterial endocarditis. So remember, larger the vegetation, the more chances of they going for the embolization. So intracardiac device can also get infected, whether the catheters or the valves, artificial valves, and here the thrombus versus the vegetation has to be distinguished, and that can be done only with the history of the fever and the microscopic hematuria and the splenomegaly. And many times the myxomas, the myxomatous valve, ruptured chordae and degenerative thickening, and all these things can be, limbar sacs also can mimic like a vegetation, and one has to be very careful in making the perfect diagnosis. And to conclude, friends, echocardiography is of a paramount importance in detecting the infective endocarditis. Many dreaded cardiac complications can be detected. That appropriate management strategies can literally save the patient from the jaws of the death. If goal is to save every single life, young and old, then echo is a must to make the diagnosis of masquerading vegetations, which can cause havoc with the stroke or embolization or anything. So these are the two masters. One is the Bob Anderson, and this is Richard Lampra, under whom I was trained. And both of them they did from autopsy. But remember, friends, echo can prevent autopsy and then save the precious lives. Thank you very much for your kind and the patient hearing. Thank you.
Thank you, madam, for your excellent deliberations on cardiac infections, particularly endocarditis, and its various plethoras of examples. Now I invite questions from other panelists or delegates, if any. Dr. Manoria, is there any question in chat box?
Dr. Vijay, Dr. Vijayalakshmi Suresh, it was just a very excellent as usual. Your presentation was very good. The slides were very good. I have questions that all the cases you presented was an emergency. Like in such a situation, if the patient is in a little stable situation, can we do a pediatric transesophageal echocardiogram to confirm the diagnosis or to see it more clearly? Like that time, the availability of probes was not there. But now, of course, that the transesophageal probes for the pediatric is available.
We have, but only the transesophageal is done when there is what to say, like the valve replacement is there, and we want to distinguish between the thymus and the vegetation or the thrombus. Then the transesophageal is required. But in pediatric, we invariably have excellent echo window. And in fact, what I have done is once I showed that 3-day-old baby, that was the intrauterine infection, and I saw almost 148 patients. Now I can detect the vegetations in the fetal echo itself. so that we can start. Many of the times people think that pregnant ladies should not be given antibiotics, but ultimately they have intrauterine infection, and the hydrosis fetalis I have seen occurring because of the vegetation in the child, in the fetus.
Thank you so much.
Okay. So with this, we move on to the next session, which will be taken by Dr. Manish Bansal. Dr. Manish Bansal was trained at Premier Institute in India and abroad. He's a recipient of numerous awards and honors. His special area of interest is atherosclerosis, CV assessment, advanced echo, strain imaging, speckle tracking, stress echo, 3D echo. He has more than 200 publications to his name. He has been a mentor to students undergoing training in cardiology and echocardiography in Medanta, and he has been invited as faculty in various national and international meetings. And he'll be speaking upon the nuances of apical hypertrophic cardiomyopathy. For this lecture, we have Chairperson Dr. Balbir Kalra, who is a senior cardiologist and chief of non-invasive cardiology, Artemis Hospital, Gurugram. He's a fellow of ASE. He's a former general secretary of IAE, and he has many publications in national and international journals. The second chairperson will be Dr. D.K. Ranawat. He's a cardiologist at Ramawat's Heart and General Medicine Hospital, Badmer. He's the author of the book entitled Ramawat's The Cardiology Today 2019. He has been trained in cardiology in reputed hospitals across the country. He has received the gold medal for his outstanding services, achievements, and contribution in the field of cardiology in New Delhi 2009. So over to the chairpersons for conducting this session.
Thank you, Pankaj.
Yeah.
Sometimes, friends, your resident comes to you running with the ECG, which shows significant STT changes, deep T inversions, and patient is either asymptomatic or has got hardly any symptoms. You know it when you do the echo. You find that the LV apex is thickened, base is more or less normal, there is no alveotic gradient, and the RWMA is not there. So you know it that it's probably apical cardiomyopathy and not the non-Q infarction. So looks can sometimes be very deceptive. To address this topic of apical cardiomyopathy, we have a learned speaker, Dr. Manish Bansal. So without further delay, may I request Dr. Manish Bansal to start his talk.
Yeah, thank you, sir, for the introduction. As Dr. Kalla mentioned in his introduction also, apical hypertrophic cardiomyopathy is often misdiagnosed. It's more commonly missed also because of the reasons that I'm going to discuss. Apical hypertrophic cardiomyopathy is a less common variant of the overall hypertrophic cardiomyopathy. It was first described in 1976 by Sakamoto, who showed that in 9 patients who had deep T inversion in precordial leads, there was significant apical hypertrophy. However, it was 3 years later, in 1979, that Yamaguchi provided more clear description of this entity with both echo and cath, and clearly showed the spade-like configuration of LV cavity both in echo and cath, and that's why we know this term as Yamaguchi syndrome also. How do we define it? There are various definitions, but the most accepted definition is that LVH predominating at the LV apex with wall thickness more than 15 millimeter at apex and maximum apical to posterior wall ratio of 1.5 or more, which could be based on echo or CMR. There are 3 main variants. One is pure form, in which there is hypertrophy only at LV apex, mixed variant in which there is hypertrophy involving other parts of LV also, but maximum hypertrophy is at apex, and relative apical SCM in which there is apical hypertrophy, but the thickness is less than 15 millimeter. Most of these patients eventually go on to develop frank apical hypertrophic cardiomyopathy. Overall, apical hypertrophic cardiomyopathy represents 8% of HCM. The prevalence is much higher in Asian countries to the tune of up to 25%. In non-Asians, the prevalence is much lower, roughly 2%. age presentation is same. This is important to remember. We often believe apical SCM to be a disease of elderly, but this is not true. Some degree of T inversion is there in almost every patient with apical hypertrophy, but giant negative T inversions, which is classical of this, is seen only half of the patients. Just like the main SCM, this is also a genetically determined entity. Same mutations cause apical SCM also, but the prevalence of mutations is much lower in this as compared to the classical form of hypertrophic cardiomyopathy. The patients can present with chest pain. In fact, chest pain is the commonest presentation because of hypertrophy at apex, and this often sustained contraction of LV apex going into diastole, which produces chest pain combined with the coronary abnormalities. In many patients, it is diagnosed incidentally, as the example which Dr. Kalra gave, because of ECG changes. Patients can also come with AF, other arrhythmias, heart failure, and thromboembolic complications. Echocardiography is the classical modality for diagnosing this. If you have this kind of images in which we can clearly see hypertrophy at LV apex in either peristral long axis view or 4-chamber, it makes the job very easy. But more often than not, echo in these patients is quite deceptive. Look at this peristral long axis view. This looks absolutely normal. So unless we go more towards apex or tilt the transducer, we'll not be able to pick this hypertrophy. And this is the reason why apical LVH or apical SCM is often missed. Now, even in 4-chamber view, apex is often quite fuzzy in these patients, and it becomes very difficult to see the endocardium. And many times these LVs are labeled as having apical hypokinesia or even akinesia or aneurysm, without realizing that what we are not able to see is dense hypertrophy. And this is another reason why it is often missed. So if we, this is another example of the same apical 4-chamber. Apical hypertrophy is not very clearly visualized. Now in such patients, if we tilt the transducer, we may be able to see endocardium and we may be able to pick apical hypertrophy. More helpful is color. If you put color, especially at apex, we can clearly see that the cavity here is markedly narrowed. So this should raise the suspicion that we are dealing with apical SCM. And of course, contrast is the modality, echocardiographic modality, which will clinch the diagnosis. So this is an example. We can clearly see a spade-like configuration of LV cavity, marked LVH. But as we know, most of us are not using contrast because we don't have contrast readily available. So in these cases, using color Doppler is also helpful, as I showed in the previous example. Now, roughly 13 to 15% of these patients go on to develop apical aneurysm also. This aneurysm forms because of sustained afterload at LV apex, combined with ischemia occurring in the LV apical myocardium. In overall SCM, the incidence of apical aneurysm is much less, roughly 2%. And the patients who develop aneurysms, they have worse prognosis because they have higher incidence of thromboembolic complications, ventricular arrhythmias, LV systolic dysfunction, and heart failure. The problem is that echo is poor in detecting these aneurysms also, because most often these aneurysms are present right at the apex and are small in size. MRI is the modality which is the most useful for diagnosing these aneurysms. And this is a very recent study yet to be published in EHJ CVI. It's in press article in which the authors looked at 1,332 apical SCM patients. 31 had LV aneurysms who were compared with 31 controls. Now, in this series, out of these 31, echo missed aneurysm in 65% of the patients, and in most of them, aneurysm size was less than 2 centimeters. So because the aneurysm is small, it is often missed. But when we compare these patients with those who did not have aneurysm, there was clearly higher incidence of adverse events. And those who had late gadolinium enhancement also, they had even worse prognosis. So diagnosing these aneurysms is very important because they are prognostically relevant. Now, there are some echo findings which can give us clue towards the presence of apical aneurysm, and one of these clues is paradoxical jet flow. Look at this in this flow here. we can clearly see two jets, one in the systole and second in the early part of diastole. This diastolic flow occurs from apex to base at the same time when mitral inflow is also coming. We can make this out better here. Mitral valve is open, this is mitral inflow, and we see flow coming from apex also. So they are flows in opposite direction. This paradoxical flow occurs because during systole, LV apical cavity is unable to empty completely because of obstruction of the mid part of the ventricle. So some blood remains. So when ventricle starts to relax in diastole, flow resumes from apex to base and we get this paradoxical flow. So whenever we see a paradoxical flow in a patient with apical hypertrophic cardiomyopathy, we should suspect aneurysm at the LV apex. The other clue that we can get is from speckle tracking. We have three examples here. First two did not have aneurysm, third had aneurysm. In all of them, we can see reduced strain at LV apex. But the patient who had apical aneurysm, there is marked reduction in LV apex. So in a patient who has got hypertrophy, LV hypertrophy, if we see this kind of picture, we should suspect apical hypertrophy. And if this is much more marked, we should suspect apical aneurysm. We must differentiate this apical aneurysm from another variant of hypertrophic cardiomyopathy, that is mid-ventricular type. So in this particular variant, there is hypertrophy only at mid part of the ventricle, and this results in apical aneurysm formation. So this is distinct from the typical apical hypertrophic cardiomyopathy and has slightly different natural history also. CMR is the gold standard modality for evaluating apical hypertrophic cardiomyopathy. It can very beautifully delineate the extent of hypertrophy. It can tell us how much systolic cavity obliteration is occurring, because this is prognostically relevant. More the systolic cavity obliteration versus the prognosis. It can show us apical aneurysm. It can show us LG, which again has prognostic significance. And now we have more newer sequences in CMR which can tell us about the myocardial structure. We can quantify T1 value of the myocardium, which correlates with the extent of fibrosis, extracellular fibrosis, and we can actually calculate extracellular volume also. In apical SCM, both are increased and both are associated with adverse outcome. Now, apical SCM is generally considered to be a relatively benign entity, but recent studies have shown that overall mortality in apical SCM is same as that in classical SCM, which is around 1 to 2% per year. Patients who are younger, those who have mixed form of hypertrophy or have mid-cavity obstruction with paradoxical flow jet, or have complete systolic cavity obliteration extending up to papillary muscle level, and those with apical aneurysm or apical dyssynergy have worse outcome. Treatment-wise, it is mainly medical management. Beta blockers and non-DHP calcium channel blockers are the mainstay. In patients who have thromboembolic complications, we have to give anticoagulants, and those who have arrhythmias, appropriate antiarrhythmic therapy. In some patients, we may have to use dual chamber pacemaker to induce LV systolic dysfunction to reduce this mid-cavity obstruction. In appropriately selected patients, ICD is also indicated. And finally, at some centers, surgery is also being done in the form of apical myectomy to relieve diastolic dysfunction and symptoms in these patients. Thank you.
Thank you, Manish, for your wonderful presentation. Tell me, Manish, you have great experience in seeing patients with apical cardiomyopathy. Have you ever come across with right ventricular apical cardiomyopathy?
No, I have personally not seen any patient with right ventricular apical cardiomyopathy. I've seen patients with RV involvement in HCM, but not specifically RV apical HCM.
Okay. It's open for discussion and comments for audience and my co-chairman.
There is one question in the chat box by Dr. Parmat, who is asking that if HCM on medical management on follow-up on echo showed development of severe MR and LA is dilated with pulmonary artery hypertension developing, how one should proceed?
So in hypertrophic cardiomyopathy, MR can occur because of various mechanisms. Most common is mitral valve structural abnormalities, which are commonly found in HCM, and now they are considered part of HCM phenotype. So in these patients, we have to evaluate the pathology that's there, and depending on the repairability, these patients should either undergo a repair of mitral valve or even replacement in some cases.
Okay.
Any other questions, comments? Welcome.
If there are no more questions, and we are also running short of time. Now there's a slight change in the program since Dr. Rakesh Gupta has some personal commitments, and we'll take the second lecture first by Dr. Vijayalakshmi, which is on evaluation of congenital heart disease, basic and beyonds. For this, the chairperson. For this, the chairperson will be Dr. Ashish Malhotra. He's a senior interventional cardiologist at Raipur. He's practicing cardiology for the last 30 years. He has done his DM from GB Pant University, Delhi, and he's a gold medal in MD medicine from Nagpur University. The second chairperson will be Dr. Asha Murthy. He's a former HOD cardiology at Sri Ramchandra Institute of Medical Sciences, Chennai. She has areas of interest in invasive and non-invasive cardiology. She has 30 years of teaching experience in cardiology, and she has received several awards, including Lifetime Achievement Award from President of India, Honorable Shri Abdul Kalam. So over to the chairpersons for this session on congenital heart disease.
Good afternoon, everybody. And we have Dr. Vijayalakshmi to speak on congenital heart disease. As you already know, she is an expert in this field, and we have to go a very stepwise approach to see the situs, the atrial connections, the valves, the ventricles, whether it's right-sided, left-sided, morphology, the arterial connections, and the embryology. We should be aware if we do not want to miss any major issue in the evaluation of congenital heart disease. Plus, we have children which are very sick, we are very irritable, how to sedate them, how to perform the congenital echocardiography itself is a very big challenge. And we are fortunate to have Dr. Vijayalakshmi to tell us how to go about it. Dr. Vijayalakshmi.
So before Dr. Vijayalakshmi speaks, I just like to give some few introduction. Already Dr. Pankaj Manoria has already given a good introduction. So first of all, good afternoon, everybody, all the faculties and all the delegates. I'd like to thank Dr. PC Manoria and Dr. Pankaj Manoria for giving me this wonderful opportunity for chairing this session of my great friend. And it is so well organized webinar, very well organized, going in on time. And I've never seen such a webinar which is going in so time. And I congratulate both of them for excellent organization. In addition to the introduction given by Dr. Pankaj Manoria, Dr. Vijayalakshmi Suresh is a doyen, is a professor, pioneer in the field of the pediatric cardiology. And almost she has been teachers of teachers for the 4 decades. Her current now has been under publication. It is under publication, that is the textbook of cardiology on cardiac catheterization, imaging from pediatrics to geriatrics, volume 1 and 2. In addition, profile of rheumatic heart disease in India. So much of academic excellence. And in addition to the professional, she has also been a social events academics excellence with a crusader of tobacco and alcohol evils. So with this, I over to Dr. Vijayalakshmi Suresh to hear about. She recently has spoken in Bangladesh, and she received a lot of appreciation for the same talk. So I request Dr. Vijayalakshmi to go on to the talk, basics of congenital heart disease.
Dr. Vijayalakshmi, you need to unmute yourself. Yeah, it's okay now.
So thank you very much for kind words, Asha, and thanks for inviting me. And this is the lunch time, and every time, we used to have lovely jalebis with rabdi in a lovely hotel, but I'm missing that. But anyway, the academic part is so excellent. Thank you very much for inviting me. The diagnosis of cyanotic congenital heart disease represents the epitome of applied clinical logic when correct inferences are drawn. Are they not seen?
No, the slides are not seen, Biji.
Okay, one second.
Yeah, now I can see the slides.
Okay, thank you. In fact, this is Joseph Perloff. When he took the bedside clinics in Hyderabad CSI, I had taken his autograph, and I was fortunate to have him as to write a foreword to my book. And then he said that it is amazing that the Indians have got so much to contribute. When you look at the classification, we divide them into AST, VST, that's the simple ones. The rare ones are, you have to remember, the 5 Ts, 3 As and 2 Es. And apart from that, the miscellaneous group are DORV, DOLV, single atrium, single ventricle. So the number goes on. So when you look at the basics, apart from the basic views, the important things in the pediatric cardiology are the subcostal and in the dextrocardia on the right side. And apart from the short axis, we have to go for the ductal view and also the suprasternal. And apart from that, even on the right parasternal region also are very important. So these are the things to be remembered. And remember the basics, as sir already told, segmental approach is extremely important. If you miss the segmental approach, your whole diagnosis will collapse like this house. And hence remember, venous segment includes both systemic and the pulmonary veins and the coronary sinus. The great veins include the systemic SVC, LSVC, as well as IVC, and the coronary sinus separately. The pulmonary veins you have to see 5, and then veno-atrial connections, and the segmental includes the distinguishing between the morphological RA and the LA, and their appendages are extremely important. Here you can see that the LA, LV are dilated, and you will be surprised. And as Pankaj showed the SVC, but the SVC should drain into RA, but here it is draining into LA. So this venous to the atrial disconnection is because of the gross, it was a total anomalous systemic venous connection. So in this patient there was IVC, SVC, everything was draining into the LA. So in the subcostal, we start with the venous connection. Here the IVC visualization, SVC, and in a bicable view you can see both the SVC as well as the IVC. And here it is very important to see whether the aorta is to the left and IVC is to the right, that is the cycle. And if it is inversus, you can see that the IVC is to the left. But sometimes you can have ambiguous. Whenever there is ambiguity, we have to go for the beyond the echo, and that is the computed tomography. And here we can see that there was a situs ambiguous mesocardia, interruption of the intrahepatic IVC with the hemiazoitis continuing, and this patient also had polysplenia. So this is how we have to go beyond our echo. Whenever the IVC is dilated and there is a set in that, and the thrombus is floating, you have to suspect that there is something abnormal in the patient. And these are the things that you have to think of: pericardial effusion, tamponade, constrictive pericarditis, restrictive cardiomyopathy, pulmonary hypertension, and AV fistulas. And apart from that, if there is an impaired flow of the stasis, and if there are any membranes we are obstructing, you have to look up. So this patient had a cyanosis clubbing, and it was a patient of DORV. On top of that, the patient had the dilated SVC, and because of the massive pericardial effusion, and then a mesothelioma attached at the AV group. So this is how, in the case of congenital, you have to think of other modalities also. And here, when you look at the subcostal view, it is very important to make out whether it is a levocardia, if the apex is onto the LV side, and dextrocardia, if the LV apex is LV is forming the apex, it is a mirror image dextrocardia, and if the RV is forming the apex, it is an isolated dextrocardia, and then it's a mesocardia. So in the subcostal view itself, you get an idea whether it is a levocardia or mesocardia or the dextrocardia. So parasternal long axis view, this is how you see everything. When you go to the segmental approach, the LV should continue as the aorta. So mitral to aortic continuity, instead of that, if there is a thick ridge, and then you have to suspect that there is something wrong. So here you can see that mitral to aortic continuity is not there, it is discontinued. So this could be a TGA, and in case of TGA, pulmonary artery arises from the ILV and the aorta from the RV. And then in the case of DORV, also you have the mitral to aortic discontinuity, and you can see that the aorta is completely arising from that. Sometimes only more than 75% may be arising from the RV. So in the parasternal long axis view, your aortic valve is beautifully seen. The aortic, the LV dilatation and the LA also are very nicely seen. And here there is a aortic regurgitation, and in the parasternal long axis you can see whether the annulus is dilated or it is narrow, whether the aorta is dilated or supravalvular stenosis is there. All can be made out in the parasternal long axis. In the parasternal long axis, you can also see in the hypertrophic obstructive cardiomyopathy, not only there is obstruction in the LV, there is obstruction in the RV side also. So here you can, mode also helps. So in a parasternal long axis view, you can see the supramitral ring as well as the divided right atrium, that is the quad triatrium sinister, also can be seen in a parasternal long axis. Now we have the 3D as well as the 4D. Here you can see that in the 4D, you have the quad triatrium sinister, and you can see from the RA side, the coronary sinus opening there. So you can see the membrane from above as well as from below or from the LA side or the RV side. And 4D echo, when we go beyond, you can see whether it is fenestrated or not can be made out. So this was a patient, 23 years old lady on dialysis, came with the severe edema. Because of the membrane, the flow was not going. So I ruptured it with the balloon and the edema disappeared and she became all right. So the subaortic membranes are known to increase in their gradient, and as the gradient goes on becoming more, it can be like a thick ridge or it can become like a tunnel. So the subaortic membranes are all shapes have to be looked for. In apical fourth chamber, this is how normally you see, but pediatric cardiologists, they invoke the image, and it is helpful for the cardiac surgeons to know the anatomy exactly the way the heart looks like. And when we go beyond, we do the PE as Asha was asking, especially when the rims have to be seen. But today, in the West, where I was trained with the Zia Hijazi, he was using the intracardiac echo. So this ICE is invasive and it is expensive, and as a result, we go for the 4D echo, and in 4D echo, you can make out the shape, size, and whether the rims are rugged or what it is. So in the past, whenever the device was not all right, in the postmortem, they used to see this is how the device, whether the endothelium is grown or not. But now you can see that in the 4D echo, if the whole endothelium is grown, you can decide whether the aspirin has to be stopped or not, and you can see it from the RA side as well as the LA side, and both the rims can be seen. So here in the 4D echo, it is so easy to make out. So this was a patient who came with the sinuses, the desaturation, and then had a pulmonary stenosis. And when I did the echo, I was not sure. I thought the patient had Swiss cheese VST. But when I did the 4D echo, I could make out that there was no Swiss cheese VST. In fact, the patient had this is how what I thought is the VST was not a VST. This is a basic echo, and there was a split, as Pankaj showed, the post-MI split of the septum, but here you can see that there is a splitting of the, or a dissection of the septum, and then when I did the 4D echo in this patient, the CT was done. This was the double chamber RV with the pulmonary stenosis, and then when I did the 4D echo, you can see that the non-compaction is so beautifully seen, and then the double chambered RV is also nicely seen, and apart from that, you can see that the septum is intact, there is no VST. So I did the balloon dilatation in this patient, and the child made a good recovery despite the non-compaction, and the failure came down, and the LV-RV function improved. So here in the 4D echo, it is almost like a pathology specimen in motion, and you get a very lovely picture. This is the triology of fallow, where the pulmonary stenosis with the intact influent septum, and there is a right to left shunt at the intraatrial septum, and the echo is good enough. In the apical flow chamber itself, you can make out whether the morphological RV is on the right side or the left side, and you have to look at the tricuspid valve attachment if it is more apical, and that is the RV. So this is the corrected transposition of great vessels with the VST and PS. And both parasternal as well as apical flow chambers are extremely good for making the diagnosis of Epstein's anomaly, and you can literally see the whip-like movement of the anterior tricuspid leaflet. This is how it is. The subtle leaflet is adherent, and that portion has to be measured in the Epstein's anomaly. This was a case of pulmonary stenosis with the VST, and on the echo I had got it as 4.6. So I took the patient for balloon dilatation and the device closure of the VST. To my surprise, after balloon dilatation of the pulmonary stenosis, when I did the LV angio, I could not find any VST. So when I came back and did the 4D echo, you can see that the VST is so small. With the color Doppler, we tend to overestimate, and when you look at it here, actually, from the LV side as well as the RV side, and it was literally closing during the systole, and that's how I did not get the VST. So this is how the 4D helps us to go beyond the assessment. And in pathology of fallow, you know the 4 features, but there is one subset where the pulmonary valve is absent or rudimentary, causing the free pulmonary regurgitation and the pulmonary stenosis. Pulmonary stenosis is due to the narrow annulus, and regurgitation because there is the pulmonary valve is, annulus is not guarded by any valve. And invariably they can be associated with the either absent RPA or absent LPA. Absent LPA is called as the Dubuque syndrome, and the intracardiac repair becomes very difficult, and the strategy has to be different for these absent pulmonary veins. And for here, whenever there is a pulmonary atresia, now we have to go beyond the echo and get the CT. Here you can make out that the pulmonary arteries are confluent, and sometimes the 3D image rendered you have to see, and for unifocalization you have to make out whether the MAPCAs which are yellow here are MAPCAs, whereas the native pulmonary arteries are seen in the blue. So this is how the 3D rendered surface reconstruction helps the surgeon to do the unifocalization, and that's how it is very important. So here you can see that this is not the ostium primum ASD, it is the dilated coronary sinus, because something is draining there. All the pulmonary veins are draining into that is the intracardiac TAPVC. So the various confluents have to be seen very carefully, whether they are draining into coronary sinus or where they are. And here you can see that the SVC RA junction, there is a turbulence, you have to suspect the TAPVC. And figure of 8 is seen in the X-ray, but we can see figure of 8 even in the echo. And this is how the ascending, that is the vertical vein, the horizontal vein, and then entering. And when we go beyond and do the CT, we can get all the pulmonary veins draining into confluence, and then vertical vein and horizontal vein. So this is how we have to combine the echo with the other modalities. So whenever there is a ground glass appearance on the X-ray, and then you have the turbulence in the hepatic portion of the IVC, you have to suspect the infradiaphragmatic TAPVC and look for it. And AV canal defect, the X-ray is excellent and that can be spoken for hours. And then this is the post-operative patient. You can see two jets. One jet is seen during the diastole, that is on the LV side, and one during the systole on the RV side. So this is the residual VST causing the VST jet on the RV side and aortic regurgitation occurring on the LV side. So the post-operative period, the assessment is very important. When you go to the parasternal short axis, whether normally we see two papillary muscles, if there is a single papillary muscle, you have to look for the parachute mitral. So whenever the Schoen's complex, you have to look for the supramitral ring. You can see that this is the supramitral ring, parachute mitral, and then you can also see the submitral and the supraaortic stenosis. So this is how the Schoen's complex also can be made out. This is the double inlet LV single ventricle in the tricuspid atresia. Again, you can see in the inverted image, and then you can look for the VST, pulmonary stenosis, and all the features, and especially the LV function. So whenever you are looking at the hepatic 5 chamber, you have to look for the overriding as well as the supraaortic stenosis. And this is how you have to distinguish between the valvar and the supravalvar stenosis. When you come to the short axis, you have to look for the unicuspid valve, bicuspid valve, quadricuspid valve, and normally you have a cup and saucer like image, but when you have side by side like Gandhi spectacles, that it's also called as owl's eye, and that is the classical of TGA, and the Maltose great arteries can also be made out. So making out the coronaries and the collaterals are extremely important, but in the echocardiography it becomes difficult, so we have to go beyond the echo and look at the reconstructed of the CT. I'm finishing, sir. So the AP window.
Dr. Vijayalakshmi,
yes,
2 minutes left.
Yes, sir.
2 minutes left.
Yes, sir. So supra-sternal view, you have to look for the coaptation, and many a times, though we get the grading, we cannot get the anatomy, and the CT is better. But in the interruption, the reconstructed 3D image is extremely good for making out. And here you can see that pulmonary artery, the PDA is directly continuing as a descending aorta. There is a total interruption. So this is how we are better. In the post-surgical, this is the Glenn surgery. Don't be happy with what you get. Just this is not a single ventricle. This is the post-operative Glenn surgery is done, and you can see that also. BT shunt can be seen. And here it appears that as if there are two aorta, but in fact it is a tunnel, and you can see that the coronary is separate. But this patient, before closing, I did the CT to see that the coronary ostia was not there on the right coronary cusp, and as a result, this is the tunnel. At the end of the tunnel, there is a device. So this is how, when you go beyond in assessing, it is important. This is the pulmonary atresia, aortic atresia. The fetal echo is extremely important, and in the fetal echo, we can see even the ectopia cordis, or name the anomaly, we can see everything. And today we have the blood speckling, where the direction of the blood, right to left or left to right, can be made out. And with this, it is very important. Gone are the days when the patients used to end up with the Eisenmengers and they used to die. And the beautiful actress Madhubala died because of the Eisenmenger's VST. And today we have all the modalities echo, and we can go beyond to make the perfect diagnosis and get a accurate and precise treatment for the patients. So friends, to conclude, in the last 5 decades, echocardiography has evolved into most useful, non-invasive, cost-effective diagnostic technology in the management of congenital heart disease. So these are Edler and Hertz, and with their ultrasound machine. So from then, MO to 2D, 3D, 4D, Doppler, color Doppler, transesophageal, intracardiac, and the fetal echocardiography journey has been fascinating and rewarding, which has made to look beyond the basics, and hence this is how we had from the basic 2D to 3D, and the 4D, and now we have the CT and MRI, like guided missiles, so precise that our diagnosis is perfect. So to friends, pathologists make the perfect diagnosis, alas, a day too late. Echocardiographer makes not so perfect diagnosis, but in time to save the precious lives. And here we have the two stalwarts or the living legends, Dr. Nanda and Feigenbaum, and this was during our last conference. And thank you very much for your kind and patient hearing. I thank Dr. PC Manoria and Pankaj Manoria and all of you for inviting me. Thank you very much.
Thank you, Dr. Vijayalakshmi Suresh, for your very excellent presentation, and I'm sure that such a tough subject of basics of echocardiography in pediatric setup is very difficult, and you have simplified in a very simple way with a very good, interesting echo pictures and with the clarity. I thank you very much. I have some few questions. How do you adopt a multimodality imaging in the setup of congenital heart diseases?
The simple AST, VST, PDA, usually we don't go beyond. Okay. But when we are doing the device closure and we are not very sure about the rims and the shape and the size, then only we go for the 4D echo.
Okay.
And in case of tetralogy of Fallot, if the coronaries are seen and collaterals are not there straight away without cath, they can go. But if there is a pulmonary atresia, we are not sure about the aortopulmonary collaterals, whether there are for universalization, you have to get a perfect picture about what are the native pulmonary arteries and what are the collaterals. For that, you have to go beyond. And apart from that, the coronary arteries, if it is crossing across the RVOT, the surgeon while doing the infundibulectomy can cut the coronary artery and it can be fatal. And in such patients, we have to go beyond and go for the volume rendered CT angio.
Okay. You have any
Vijayalakshmi, I would like to ask that with all these 3D, 4D modalities and CT, etc. developing, is there any role for transesophageal echocardiogram? Which subset would you like to use transesophageal echocardiography in pediatrics population?
Pediatric patients, we hardly require, sir. During the AST closure, I don't use the transesophageal. But adult cases, if you are doing, then you have to have the transesophageal while doing the device closure for the AST.
Dr. Vijay.
With this, I think that is, with this, the session is concluded. Please, it's already late. Move on to the next session.
Thank you, sir.
The next session is on Tokoshobu syndrome vis-a-vis acute coronary syndrome. And the speaker for this session is Dr. Samir Srivastav and the chairpersons Ashok Tehlani from UK and Abhay Pandey from Dubai. Dr. Samir Srivastav, all of us know, is Director Non-Invasive Cardiology at the Fortis Escorts Heart Institute, New Delhi. He's past Editor General of Indian Academy of Echocardiography. Special interest in echocardiography, TE, stress echo, intraoperative echo, critical care, and CT angiography. He has been the past Secretary of the Indian Academy of Echocardiography, past Joint Secretary, Executive Committee, CSI, Associate Editor, Cardiology Update 2011, and has received several awards and orations. The chairperson, first chairperson is Dr. Tehlani, consultant cardiologist, North Devon Hospital, UK. He has many publications in national and international journals and has delivered several lectures at national and international conferences. And the next person is my friend, Dr. Abhay Pandey, consultant interventional cardiologist from UAE. He has been practicing intervention cardiology for the last 16 years. He has obtained fellowships in various fields and he has more than 50 publications in national and international. Over to the chairperson for conducting the session, Dr. Tehlani and Dr. Pandey.
Good morning. Well, it's a bit of time difference here. We just woke up early 6 morning and glad to see Dr. Manoria with Dr. Vijayalakshmi and all some of my colleagues, Dr. Pandey. So I'm still half sleepy, but never mind. I think Dr. Srivastava is going to wake me up, caffeinate me with excess coffee then. And so I guess, yeah, Tokusuba cardiomyopathy, as we know, that's kind of very important subject and often missed. So we'll hear Dr. Srivastava first, then we'll have a quick chat about it. Over to Dr. Srivastava, please.
Thank you very much, and thank you very much for the invite. This was supposed to be presented by Dr. Rakesh, but for some reason he is not available, so I'm doing. I just hope that I justify his absence here. So acute coronary syndrome versus Takotsubo's syndrome. For those people who are in the audience who are not familiar with this Takotsubo, it is basically an acute cardiac syndrome which presents like acute coronary syndrome. There is a transient LV apical ballooning in absence of coronary stenosis. So one major issue is that the coronaries have to be normal, often precipitated by acute emotional or physical stress, and also known as broken heart syndrome, stress cardiomyopathy. Several names are there. And why is this it's an acute cardiac syndrome, and it is several times misdiagnosed and possesses a bleeding risk to the patient through thrombolysis. So it is so important that we must differentiate acute coronary syndrome from Takotsubo, because several times you'll have ECG features which are classical for ST elevation MI. You would want to do something about it. You may not want to do it, but awareness of Takotsubo's and the risk of demographic is of vital importance. Clinicians should include Takotsubo in their differential diagnosis in cases of acute coronary syndrome that show no coronary artery disease. Now, what is the frustration? The biggest frustration is that you cannot differentiate between Takatsubos and ST elevation at a presentation many a times. It is only a surmise, but many a times you are not able to. And since it is such an important disease to rule out, it is always better to be more sure than only go on your intuitive guesswork. So historically speaking, there will be about one-fourth of the patients who will have acute emotional stress, unexpected death in the family, confrontational arguments, severe anxiety, bereavement. These are all things which secrete a lot of adrenalines. And sympathetic outflow is one of the etiological factors which have been implicated. Not too sure whether it is the only or it is an additive one, but this is something which is certainly a very important factor. You can't ignore it though. Physical stressors is seen in 30% of the cases, so like asthma, exhaustion, sepsis, postpartum. There are several ways in which you can find the history of physical stressors, but there is a good about a third of patients where you won't be able to find. So Takotsubo is basically octopus entrapment vessel, which the Japanese used to use, in which the octopus would enter but cannot come out. And when you look at the LV, whether it is in LV gram by an angiography or whether you do it in an echo, you'll find that there is a restriction at the neck or at the bases, and the LV starts to balloon. Now, what are the Mayo Clinic criteria? So, there is a new ECG abnormality, but the caveat is that this new ECG abnormality should not be associated with head injury, intracranial bleed, pheochromocytoma, myocarditis, or hypertrophic cardiomyopathy. Number two, there should be an absence of obstructive coronary artery disease. So it is very important that when we make a diagnosis of Takatsubos, we must have a non-obstructive coronary artery. And there should be transient LV apical akinesia or dyskinesia, but aneurysm is something which is very rare. So let me just discuss the differential diagnosis of weak and enlarged ventricle. Here is an example of a stress cardiomyopathy where if you look at it, the bases are hypercontractile and the apex is kind of ballooned. This is a very, very interesting feature where this may not several times conform to the coronary artery distribution, but it conforms to the distribution of the sympathetic nerves, so to say. Now, here is an example on the left. There is a ballooned up syndrome with hypercontractile bases again. And on the right, if you look at it, there is an improvement which is seen after almost about six months without intervention. Now, this is a classical Takatsubos. I'll play it again for the benefit of people. This on the left is a ballooned up apical ballooned syndrome, though we have now started seeing more of non-apical ballooning also. It can be selectively on the right side, lateral side, it could be at the inferior or the posterior. So there is not necessarily that it has to be apical, though it was classically described as an apical ballooning syndrome only. Now, where is the confusion coming? The confusion is coming because there is a new term which has been extrapolated, which is called myocardial infarction with non-obstructive coronary arteries. And it is MINOCA. So this is clinically defined as the presence of a universal acute myocardial infarction criteria that there is an absence of critical coronary artery stenosis. That means the blockages are not greater than 50% of the cross-sectional area. No overt cause for the clinical presentation is seen at the time of angiography, and classical feature of Takotsubo's cardiomyopathy are there. Now, this was discussed and debated, and it eventually came into the guidelines as one of the types. But the problem is that there is something known as a troponin positive non-obstructive coronary arteries. Now, this is MINOCA, where you label it as MINOCA if you have coronary dissection, blast disruption, coronary spasm, microvascular dysfunction, coronary thrombus, or embolus. And there is a myocardial disorder where troponins can be raised, but are seen in myocarditis, Takotsubo's cardiomyopathy, and other cardiomyopathies too. And then there are certain non-cardiac disorders like pulmonary embolism, or there is renal impairment. Now, having discussed this, we now understand that troponins are the mainstay for diagnosis of coronary artery disease, acute coronary syndromes. Non-atherosclerotic mechanisms contribute to a substantial number of acute coronary syndromes. So yesterday was yet another thing that in MINOCA they said that you have to have some bit of a coronary artery disease, and over or above there is an element of spasm which was discussed, and that is yet another mechanistic study which was done for MINOCA, which was published, discussed in the American Society 2 nights back. So non-atherosclerotic mechanisms contribute to a substantial number of acute coronary syndrome events and require specific diagnostic strategies. Spontaneous coronary dissections, if it is seen, then well, it is MINOCA. Most common in younger women and preferred strategy for conservative treatment. Coronary embolus also can be seen very well. Coronary vasospasm, though, is difficult to see, but there can be an issue that you can make out, because coronary vasospasm almost always occurs over an underlying plaque. So if there is a plaque, then you can also surmise, but where is and how do you make a difference? And myocardial bridging is a theoretical possibility always, which can lead to an acute coronary syndrome. But what we see is stress-induced cardiomyopathy, which is frequently associated with endothelial dysfunction and can acutely cause outflow tract obstruction. Now, this was discussed, debated, and now look at the frustration which adds on further. The frustration is that Nature's Review Cardiology, which was published in this year only, said that there is a typical clinical presentation of Takotsubo's myopathy, which mimics that of ACS. In the same article later, it says that Takotsubo's is a notable cause for non-atherosclerotic acute coronary syndrome. So hardly there is a very thin margin where you can differentiate acute coronary syndrome from that of Takotsubo's, because this is also classified somewhat like an acute coronary syndrome. We are clear, if we have things of this sort where there is an aneurysm formation, if there is a thrombus formation, if there is calcium, we know that it is ischemic. Now, there is a dilated cardiomyopathy. So whenever we are talking about acute coronary syndrome versus Takotsubo's, we are looking at reversible versus non-reversible, because Takotsubo's by definition has to be reversible. However, if you feel that there is some bit, you can look at dilated cardiomyopathy where globally there can be hypokinesia, though the caveat is that even in dilated cardiomyopathy, 40% of the patients can present with regional wall motion abnormality. Now, there are a few things where if you look at the ECG versus echo profiling, then you can really differentiate whether it is ACS or whether it is Takotsubo's. Now, here is an example of a non-compaction. Now, if you look at non-compaction, if you look at the ECG, there is a dichotomy. There is a huge tall R wave. This tall R wave negates ACS. It negates Takotsubo's too, because if at all, but there is a distinct feature here that you have to have recesses which can be there. Number two is that whatever little I understand of Takasubos, though I can't say that I am an expert on it, but yes, we have seen a few of Takasubos ever since it has been described, but I have yet to find a Takasubos which has got an intracardiac thrombus. So if you find an intracardiac thrombus like this, either it is ischemic or it is dilated, but certainly it, to my mind, is not a Takasubos. Non-compaction is a very close differential diagnosis, and but if you have to really cut it thin, then for non-compacted LV, your ECG echo dichotomy exists, more than 3 recesses exist, and compacted to non-compacted myocardial ratio is 2:1. Now coming to the brass differences between acute coronary syndrome and transthoracic, the term acute coronary syndrome is supposed to mean any group of clinical symptoms compatible with acute myocardial ischemia and includes unstable angina, non-ST elevation MI, and ST segment elevation MI. Now, Takasubos is described by ACC and AHA as a distinct morphological manifestation of stress cardiomyopathy, characterized by transient left ventricular dysfunction, electrocardiographic changes that can mimic but are not those of acute myocardial infarction, and minimal release of myocardial enzymes in the absence of an obstructive coronary artery disease. Therefore, according to this taxonomy, the term ACS is not synonymous with TTS. It is in the same article that which said that to differentiate it, Takasubos is classified, and sometimes, so they keep going this way and that way, defining Takasubos, whether it's a part of ACS or not. Now, when it comes to coronary arteries, their primary role is for ACS is because of coronary artery, but however, coronary arteries are normal, no effect on brain, on heart. However, when it comes to Takasubos, it has to be a very intense sympathetic surge. Wall motion abnormalities according to blood supply of the coronary artery. However, in Takasubos, wall motion abnormality is not according to blood supply, and there is a ballooning which is apical or basal ballooning in transthoracic. Wall thickness abnormalities are also an issue. I'll just talk about Takasubos. Wall thickening abnormalities are congruent with the distribution of cardiac nerves. Now, ACS happens because of cardiac arteries. Takasubos occurs because of nerves which are mapped by anatomists. However, we don't know clinically that how to map them clinically. And this is the supposed microvascular spasm, which may be an epiphenomena rather than the cause for Takasubos, and it is reversible. Histologically, now this is something posthumously you can make a diagnosis or pick up a biopsy, which is too gross a thing to be done to make a differentiation between Takasubos and acute coronary syndrome. But in acute coronary syndrome, if you look, there is an ischemic myocardial necrosis, and the cells die in an atonic stage with no myofibrillar damage. However, in Takasubos, cells die in hypercontracted stage. So this is, as against atonic, this is hypercontracted because of the sympathetic outflow excesses, and with an early myofibrillar damage and anomalous irregular crossband formation. These cardiac lesions, termed myocytolysis, are caused by direct effect of catecholamines on cardiomyocyte beta adrenergic receptors and are not primarily mediated by vasoconstriction. And these lesions are not located around the vessels, but are at the end of intracardiac nerves. Now, these are certain thoughts which I just want to show that where are we? There are certain non-specific differentiator, history of physical or mental stress. Both, whether it is Takasubos or whether it is acute coronary syndrome, both get precipitated by physical or mental stress. So this is a soft differentiator. Number two, troponin values, though of some value, if grossly disproportionate, are of importance. Now, this is a very interesting feature that for a LV function, which is 25 or 30%, if you have minimal raise of troponins, then you are sure that, not you are sure, but it is suggested that you are dealing with a stress-induced cardiomyopathy. Because if there is a disproportionate LV dysfunction and lesser of troponins increase, then you are, this is suggestive of Takotsubo's rather than acute coronary syndrome. Now, BNP and anti-pro-BNP values are non-specific, and ECG is non-specific, certainly. So this is what I was saying, that when I said that cardiac enzymes are disproportionately less. So if you look at this, so initial troponin I in Takotsubo's, say if it is 1.1, in ST elevation it will be double. Peak, if it is 4.9, in ST elevation it will be double. However, the ejection fraction in Takotsubo's is 33%, ST elevation MI it is 25%. So troponin I rises in Takotsubo's, and the peak rise is disproportionate to the level of LV dysfunction. Now, there are certain things, these are my own personal thoughts, and I would be very happy for people to get into a debate. There are certain points in favor of ACS, and these are in descending order. So if you find that there is an apical aneurysm, because submitral aneurysm, subaortic aneurysm, these are our congenital issues. If you have apical aneurysm or pseudoaneurysm, this favors acute coronary syndrome, no question. Intraventricular thrombus is very less found with Takotsubo's. I have not seen it, and that's the reason, though I have not conducted trials, but this is my observation, that intraventricular thrombus favors something else other than Takotsubo's. Let me put it like this. Regional wall motion abnormality specific to a coronary artery territory favors acute coronary syndrome. And there are certain things which are in favor of Takotsubo's, which is apical ballooning. Apical ballooning is reasonably safe for you to define, along with a hypercontractile base. These are two things which favor Takotsubo's. So diagnostic wisdom is that high index of suspicion, especially in distressed postmenopausal women, because 9:1 is the ratio of women to men. Rapid improvement once incremental factor is taken care of, and it has got an excellent prognosis. This is what I need to say about Takotsubo's. Thank you very much for a patient listening. Shall be happy to take any questions.
Okay, so Dr. Srivastava, that was a wonderful presentation. And I think you summarized it quite nicely, actually. A few things I would rather add on with regards to the discussion that we had. Firstly, the brain involvement. I mean, there's no direct brain involvement, but what happened is the catecholamine release is very, very high. And we mentioned that what are the things that we can do to diagnose Takotsubo as opposed to the ACS. Yes, there is no nerve mapping, totally agree. But what we have been trying here in London with the rest of my colleagues, we are trying to monitor the catecholamine levels. Now, this is at the preliminary stages now. We don't know. The issue that we are facing now basically is how high should be the catecholamine level. So that's what we have been debating. So hopefully with the new webinar or the next upcoming webinar under Dr. Manoria, I'll probably be able to give you the cutoffs with how high the high catecholamine level will point out to the Takotsubo cardiomyopathy. Now, the one thing that I miss, and I would rather love to hear now your presentation, but I will cover it up, is about the treatment management. How do we go about this management? I think essentially, of course, beta blockers and ACE is the mainstay of the treatment, but the problem comes when you have the Takotsubo cardiomyopathy with the LVOT obstruction. And that's where the interventionist role comes in, basically. And, one of the things that I've been trying quite successfully here with the rest of my colleagues in my previous center is just using the as in the very early stages. So that was something we need to really look on. And of course, otherwise, the mainstay of the treatment is supportive. I mean, if you do not have any LV obstructions and all, I think just pump filling in and increasing the preload and the things like that will help. Yeah, I think otherwise it was fantastic presentation.
Thank you, Dr. Delhi.
Dr. Pandey, you want to say something? You are muted. Dr. Pandey, you are muted. Please unmute.
Dr. Pandey, you need to unmute yourself.
Dr. Pandey, you are muted.
It was an excellent presentation, and it's an important thing that every clinical cardiologist has to know, because the Takotsubo or broken heart syndrome has an excellent prognosis, and as opposed to the coronary artery disease, and we must keep this in mind while treating. It comes into play in about 2% of our patients. I congratulate Dr. Srivastava for an excellent presentation. He has covered everything. And as far as Ashok was saying, it will be very difficult to define what is the output of the sympathetic nervous system and how to differentiate between that, because the level with this. Yeah. Over to you.
Thank you. We now move on to the next session, which is a very interesting topic: regional wall motion abnormalities with normal coronary angiogram. How should I proceed? And the speaker for this session is Dr. Sanjay Mittal, whom you have already heard. And the chairpersons for this session are Dr. Sunil Kumar Verma. Dr. Sunil Kumar Verma is a consultant cardiologist at Haria Hospital, Vapi, Gujarat, formerly associate professor in Department of Cardiology, AIIMS, Delhi. Many publications in various journals, and CAD is area of interest. And the other chairperson is Dr. Dudwe, consultant physician and critical care specialist at Francis Hospital Research Center, Indore. Over to chairperson for conducting the session.
Good afternoon, sir. Dr. Manoria, thank you. And it was up to now, it's a very excellent workshop. And I am most thankful for organizing such a nice conference, Dr. Manoria. Coming to that topic that is being covered by a very renowned cardiologist, Dr. Sanjay Mittal. We have seen his earlier presentation. They were very useful. A very important and usual, very common clinical topic, that's RWMA with normal coronaries. How should a clinician, physician, or cardiologist should proceed? And Dr. Sanjay Mittal is going to talk about this. Welcome to Dr. Sanjay Mittal.
Thank you, Dr. Sunil. It was important, and it's also important to discuss this topic after listening to Samir Srivastava. Wonderfully, he covered one of the diseases which could show us regional wall motion abnormalities in presence of normal coronary arteries. I'll dwell it a little bit further. First of all, what do we understand by regional wall motion abnormality? Regional wall motion abnormality means that the whole left ventricular wall is not equally dysfunctional. It is only a small segments which are dysfunctional. And if I look at this disease status where there is regional wall motion abnormalities without coronary artery disease, I can divide them into two categories. One, those types where there is no correspondence to the coronary distribution, and the other where there is a corresponding coronary distribution. The second part, Samir Srivastava did deliberate on, and I'll possibly cover in the second part of my second half of my discussion. But most importantly, how to distinguish the coronary distribution. This is very important, and that is when we should actually progress to when we are doing a clinical examination. So when we talk about a situation of regional wall motion abnormality in the absence of coronary artery disease, we have two tasks at our hand. First, do not conform to a coronary vascular territory. And second, always try to focus on thickening rather than the passive movement which could be there. So it's not the movement we are focused upon, and it's only on thickening or ventricular thickening during systole. And this can be done by phrase-to-frame analyses by a naked eye as well. So a word about the LV segments. We know that the parasternal long axis view, 4-chamber view, and 2-chamber views can be divided into the various segments in the left ventricle, the basal, mid, and apical, basal, mid, and apical, which could be the inferior wall or the anterior wall, or the septum or the lateral wall, or the basal posterior and the anterior septum. And the same thing could be visualized in the various short axis views. Mind it, importance is to understand that all these segments predominantly are supplied by different coronary artery substrate. Here in this particular diagram, it's a wonderful diagram which shows the dark blue ones. That means these areas are invariably supplied by right coronary arteries. The green one is supplied by the left anterior descending artery, and the circumflex, the pink one, is supplied by the circumflex artery. There is a huge bit of superimposition. The blue and the pink one is right coronary and circumflex common territory. This is the LAD and circumflex territory combo. So if we have this kind of a picture, we can keep this in our lab, and while evaluating our wall motion abnormalities, see whether it is confounding to a particular coronary artery territory as well. Secondly, many a times also it would happen, say for example, in the LAD, the distal LAD is going to be invariably involved if the proximal LAD is involved. So it is very unlikely you have wall motion abnormalities in the proximal LAD, although diagonal disease can happen, but very unlikely to have proximal LAD involvement, wall motion abnormalities, with preserved apical wall motions. So these are the things which we have to keep in mind while we are assessing whether the wall motion abnormalities are confounding to coronary distribution or not. The second thing is that we have to focus or learn to focus on thickening, segmental thickening rather than motion. Why? Because that is how the definition is. Although the terms here on the left side are all motion dependent, but the description or definitions are thickness dependent. So it is, although normokinetic, but it is more than 50% thickness. Sorry for the hypokinetic is 10 to 30% of thickening. Akinetic is less than 10% thickening because that cannot be perceived by the naked eye. And dyskinetic is in systole, there is, instead of thickening, they're thinning out of the segment in systole. And the same thing can be utilized to give us a score. The higher the score, the worse is the prognosis, because larger area of infarct is possibly what we discuss about. And the larger area of myocardial damage is what we think about. So this is an example of all the things which I could dream about, where there is abnormal contractility or abnormal apparent contractility with no coronary artery disease. In this ventricle, you can see the septum seems to be hypokinetic, but if you focus on the thickness, it is individually contracting as much as 50%, although it is in a different phase. Same thing you can see in the parasternal long axis view, and this is a very common thing which we find in left bundle branch block or right ventricular pacing or WPW syndromes. This is something which is very common. We would make inadvertent errors if we consider these as hypokinetic, but this is actually a normal thickening in a different phase, and that's what is a hallmark of left bundle branch block. In parasternal long axis view, if we have M mode, it can be very well seen, the septal beaking, which is there in the early phase of systole or very early or late phase of diastole, because this is the systole of septum, and this is the systole of the lateral wall, which is the hallmark of left bundle branch block. Many a times, Samir did mention about 40% of people would have a wall motion abnormality, although they have dilated cardiomyopathy. And whenever we have a common septum involvement or the basal inferior wall involvement alone, we should think about possibility of sarcoid or other kind of restrictive cardiomyopathies going haywire. So this is a classical example of septal hypokinesia in dilated cardiomyopathy. Many times what we find is wall motion abnormalities. If you look at this particular septum, this is jerky and this is not as smooth as the posterior wall. Also, you can see the hallmark of the posterior pericardial cavity, which is thickened and suggestive of constrictive pericarditis. This is classical of constrictive pericarditis. And you can see the septal bounce. What is important is the septal bounce happens both in systole and diastole, and I will show you the image in the M mode. You can see the septal bounce, which happens both in systole as well as diastole. So this is something which we should know and should evaluate, and its hallmark, although there is no coronary artery disease, but there is a disease which can be ascertained. Another example where we can have septal abnormalities is when the right ventricular pressure and volume is overloaded. So in the volume overloaded, the dysfunction or displacement of the septum towards the LV would be in diastole, whereas it would be systole as well as diastole in pressure overload right ventricle, as is classical in this case. You can see the pressure overload, the PA pressures was almost like 100 millimeters of mercury in this particular patient. So the regional wall motion abnormality in absence coronary artery disease could be of so many reasons. This could be because of just tardokinesis, because of early relaxation, left bundle branch block. I showed you the example, ventricular pacing, pre-excitation, post-operative state also, because the septum shifts towards the right ventricular side because of the pericardial opening. This is a very common state. Pericardial diseases is again, which I discussed about, right ventricular pressure and volume overload. External compression also can produce wall motion dysfunctions or displacements. And last but not the least, I would like to just hurriedly go through what Samir had discussed, a very important aspect of wall motion abnormalities without coronary obstruction. And I give you an example. This is a 46-year-old non-smoker man, past history of hypertension for a month. Angiography 10 years back also showed non-critical coronary artery disease, presents with breathlessness on exertion for last 3 months. It's not an acute feeling. Blood pressure was by 70, tropi was not elevated, and what the LDL was 139 was high. So the ECG did show Q waves in the lateral leads, but with well-preserved R waves, and this was what was seen here. And you can see the left ventricle, basal and mid segments were preserved, but apex was ballooned up and dyskinetic. In the parasternal long axis also, there was a ballooning up at the apex. What we did was an angiogram. The angiogram did not show critical coronary artery disease, although right coronary artery disease was showing about 50% lesion here. LAD was practically normal. So what do we do here? Is it Minoka? Well, Minoka could not be there. Why? Because the tropi was not elevated. So this is apical wall motion abnormalities without coronary artery disease. There could still be a coronary artery disease or something else. Maybe the damage happened earlier because dyslipidemia was there. History of coronary non-critical lesion was there, but CAD was non-critical. So that's what the Minoka differential diagnosis Samir also discussed about. It could be vasospasm, it could be coronary slow flow, microvascular angina, or vascular spasms also. It could be plaque disruption or rupture or dissection. Samir did mention that Takotsubo cardiomyopathy is considered to be non-coronary causes because of the stress cardiomyopathy and is not ranked into the Minoka syndrome. So in our patient, what we did was we did MRI. What MRI showed was this is an apical ballooning, aneurysmal, which was thinned out and scarred. So this kind of a myocardium is not likely to recover. The late gadolinium were there and ejection was less than 40%, but also what it found was there was some obstruction or hypertrophy at the mid levels. And so very commonly what we find is if there is mid-cavity obstruction, Dr. Ashok Tahilani was mentioning about the LVOT obstruction, but even in a mid-cavity obstruction, such kind of patterns could be seen, and there's hardly any treatment which can be offered for this particular patient. Last but not the least, this is how the guidelines have suggested to go for the Minoka management. First, a clinical suspicion. If there is a clinical suspicion, first thing we have to do is confirm whether the cardiac enzymes or troponin I was elevated because of some other reason. That is, it could be sepsis, it could be pulmonary embolism, cardiac contusion, or non-cardiac causes of troponin C elevation. Second is when we have a non-obstructive coronary artery disease, we have to lead to further evaluation by a cardiac MRI for formation of scar or aneurysms, and also for an angiogram to reconfirm whether there was obstructive CAD. Sometimes we may have missed because it may be eccentric lesion which may be missed on some of the views. Coronary embolism, or which could be thrombolized spontaneously, and by the time we do an angiogram, the thrombus is not there, or dissection. Sometimes on a superficial assessment of angio, we may miss them. Finally, if both of the things are confirmed, that means there is no substantial obstruction and the tropi is elevated, we have to establish the diagnosis of MINOCA. And this is something, again, we have to think about reversible causes as Takotsubo cardiomyopathy or some of the cardiomyopathies such as sarcoid or amyloid, or myocarditis also many a times may be reversible, specifically if the infection or inflammation goes away. But many a times it remains and results into a dilated cardiomyopathy. So the cardiac MRI confirms whether there is an infarct or scarring or not. Unfortunately, echocardiogram, there is no gold standard as of now for identification or quantification of scar. A plaque disruption, coronary embolism, and dissection may actually have been there or missed or repaired on its own. Coronary vasospasm can be assessed by functional assessment or microvascular disease. And unfortunately, 30% of them would still have an unclassified MINOCA. Thank you.
Thank you, Dr. Mittal. It was very nice coverage of each and every aspect of the very important clinical entity that we frequently come across. And sometimes anomalous coronary arteries is one of the important causes that are also contributing to regional wall motion abnormalities with normal coronaries that are usually detected with CT angiograms. And myocardial MRI and the myocardial diseases that contributes are also important part that has to be given a thought about this occurrence of regional wall motion abnormalities with normal coronaries. If we have any question, that the sir is with us and we can.
Yes, Dr. Dudwe. Dr. Dudwe, go ahead. Dr. Dudwe.
Segment है viability. Yes, sir.
Yes, Dr. Dudwe, you are asking something. Viability assessment you're talking about?
No, he's saying akinetic segment, can it have viability?
Yes, absolutely. Akinetic segments can have viability, and that is one of the things when even Takotsubo cardiomyopathy, the segment may be ballooned or akinetic, but still viable, and it's likely to improve over a period of time. In ischemia also, you can have viability, and there is a different way to assess viability. Low dose dobutamine stress echo or cardiac MRI or PET scan can be used to actually assess for the myocardial viability in akinetic segments.
One more question: can you differentiate wall motion abnormality of CAD from myocardial disease?
Well, yes and no. Dr. Samir Srivastava very beautifully mentioned about the controversies. You know, the basic diagnosis of Takotsubo cardiomyopathy is only after two things. One, the angiography has to be absolutely normal. And second is there has to be likelihood of almost complete recovery over the next few weeks. So then we talk about the stress cardiomyopathy or Takotsubo cardiomyopathy. So that is something which we have to understand. As far as ischemia is concerned, yes, there is huge bit of difference. Presence of scar. Dr. Nanda was mentioning a few hours earlier about a notation of presence of echo-referringent scar or white tissue. The higher the amount of whiteness or scarred or fibrosis, the less likely of that area to recover back. Unfortunately, ischemia is not the thing which would lead to that fibrosis. It is infarction. So ischemia and non-ischemic cardiomyopathy cannot be differentiated. Yes, if it is a prior infarct which has led to scarring, you may have an inclination by a surface echocardiogram, but not between ischemia and non-ischemic, where the scarring is not there.
So thank you. We now move on to the last session, and the last session is on diastolic stress echo utility in clinical practice. And the chairpersons for this session is Dr. Hired Kumar, he's an honorary national professor of medicine, past president CSI Bihar chapter, senior consultant cardiologist, Indira Gandhi Institute of Cardiology, Patna, and Dr. Abhishek Siga is assistant professor, Department of General Medicine, AIIMS Bhopal, and he has published 52 research papers in various national and international index journals. Over to the chairperson to conduct this session.
There is no need to introduce Dr. PC Manoria among the cardiologists of India. Still, I will formally say only few things that Dr. PC Manoria had been president of the National CSI India, National API India, National IC India, and so many things, so many associations. He is everywhere, and he is a teacher of the teachers, and he has written more than 100 books, as I know. He might have written more than that, but I know 100 books he has written. So this is, there is no further need to tell about his achievements. So over to Dr. PC Manoria, sir.
I think most of us are getting hypoglycemic, so we will finish in 5 to 7 minutes. All of us know diastolic stress test is a test done to unmask the diagnosis of heart failure with preserved ejection fraction. And heart failure with preserved ejection fraction is a common problem encountered in our day-to-day practice. The diagnosis may be problematic because of non-specific symptoms. The natriuretic peptide levels may not be elevated. Resting diastolic parameters may be equivocal. And about 30% of patients with HFpEF may have normal resting diastolic function on Doppler, and diastolic stress echo clinches the diagnosis of HFpEF in this subset of patients. All guidelines across the globe, they mention about diastolic stress tests. As you can see here, this is American Society of Echocardiography, or with its Heart Failure Association of ESC, or the Mayo Clinic latest heart failure guidelines. What is the necessity of a stress echo? The necessity is to evaluate cause of an external dyspnea in a patient who is a normal ejection fraction, or who's a normal ejection with normal or equivocal resting diastolic function on a Doppler, giving a false idea of absence of HFpEF, or patient has dyspnea, normal functioning test, normal ejection fraction, or patient has no coronary artery disease and his ejection fraction is normal and he has a shortness of breath. So exercise echo increases diastolic pressure in the ventricles, unmasking the normal resting diastolic pressure. And this phenomena has been reported in 40% of patients according to a study in the Korean journal and about 20% in a JACC journal. Now, what is the response in a normal person? Normally, the E velocity increases and the E prime also increases. So the ratio of E I prime remains same. In HFpEF, E increases and E prime remains same or decreases. So E by E prime also increases due to stiffer ventricles. And this is graphically shown here that when a normal person exercises, because of increased load on the ventricle, the pulmonary capillary pressure or left ventricular end diastolic pressure is not increased. But if your ventricles are stiff, if an increased load comes, your LVED is increased. This is the normal response in a normal person. You can see E by E prime is 8:1. If the same person exercises, E by E prime remains normal. So what is the positive criteria of a diastolic stress test positive? According to ESC, patient should have shortness of breath on exercise. E by E prime ratio should be more than 14, peak PR velocity more than 2.8 meters per second, and PASP more than 35. Dobutamine stress echo is not recommended for diastolic stress because dobutamine is a vasodilator. I mean, in decreased left ventricular filling pressure is not physiological for evaluation of dyspnea on exertion. It can be performed invasively and non-invasively. Usually it is performed non-invasively. What are the current indications? When resting echo and PFT does not explain the cause of an exertion, or you have a grade 1 diastolic dysfunction, dyspnea on exertion, or you have indeterminate E by E prime ratio, when this test should not be performed. Patients with normal hearts and normal diastolic function, there's no necessity. Patients with abnormal diastolic function, even at rest, consistent with increased left ventricular filling pressure, there's no necessity. It can be performed either by a supine bicycle or by a treadmill or even by passive leg raising. And the passive raising, the leg raising is raised for 30 minutes and you produce increased load on the ventricle because of increase in the filling pressure, and that precipitates increase in the LV filling pressure if patient has HFpEF. And passive leg raising is also incorporated in various guidelines. This is a diastolic test by passive raising. You can see on the upper panel, E by E prime was 12, but on exercise it became 18, indicating that the patient has HFpEF. Post-exercise protocol, usually we start with evaluation of regional wall motion for 90 seconds, and usually after 2 minutes, the Doppler study is started, and various Doppler slopes get stable. Changes of raised LVFB persist for 4 to 8 minutes. So the stress, diastolic stress gives an idea about both the CAD as well as the HFpEF. And here's an example where the patient shows abnormal test. Even at rest, you can see the E by E prime ratio is more than 14. And this is a patient where the resting parameters were normal, and the patient is made to exercise. His E by prime ratio is indicating clinching the diagnosis of HFpEF. Now, this is the story which tells you what is the importance of doing this test. This is a 52-year-old gentleman, diabetic, hypertensive, started having exertional angina. His stress echo shows individual ischemia and LED territory, CAG done, LED 90% stenosis, underwent revascularization with PTCA, became asymptomatic, back to work. 18 months after PTCA, started having exertional dyspnea, no angina, TMT normal, CT, patent LED, echo LVH, normal EF. Patient was sent back home, and he was asymptomatic for quite some time, but later on started developing shortness of breath, and the resting echo was normal, and the angiogram was also normal. But when diastolic test was done, you can see the diastolic stress test was positive. The E by E prime ratio is 20 to more than 20, and therefore this is a patient of HFpEF. And when diuretics were administered, the patient became asymptomatic and back to work. So the take-home message is, it is a valuable test for documenting HFpEF in patients with normal resting Doppler parameters. The symptoms of exertional dyspnea in a group of patients with grade 1 diastolic dysfunction, normal PFT, no CAD, should not be ignored and should be tested by a diastolic stress test. Thank you.
Dr. Manoria sir has delivered an excellent lecture. Sir, I have few questions. Can dobutamine stress echo can be used as a for diastolic stress test?
Now, dobutamine stress echo should not be used for, because it produces vasodilatation and therefore it is not, does not increase the preload. It is not recommended. Should not be used.
Okay, sir. Thank you. One more question, sir. Can fluid overload be used for diastolic stress test?
Fluid overload can be used, but the same thing you can do by passive leg raising, because if you administer fluid, you will not be able to revert it back, and patient may heart failure may be precipitated. So best thing is to have a leg raising. You can reverse it back immediately. So fluid laboratory has been used for diastolic stress test, but this is a better strategy rather, because once you administer, you will not be able to revert back.
Okay, sir. Thank you.
I have a question, Dr. Manoria. That was a fantastic presentation. Just a quick question about the use of MRAs in HFpEF. What your strategy? Would you prefer spironolactone, eplerenone, or none in cases of the HFpEF?
HFpEF, there is no treatment which has changed the outcome. There are some reports that the mineralocorticoid receptor decrease pharyngeal edema in the subset of patient who has obstructive sleep apnea. And this can be used if the patient will have HFpEF, if you have a diminished GLS, indicating that this patient, which is labeled as HFpEF on the basis of ejection fraction, is also having systolic dysfunction, and this subset of patient has been found to be useful in the Paragon trial. And actually, heart failure should not be clearly demarcated into HFpEF merely by a number. There's an overlap and it is a continuum. So we can say ejection fraction more than this is HFpEF, ejection less than this. So it's a continuum. So over a period of time, it changes over. And most of the patient has a combination, so that you can have HFpEF can have systolic dysfunction as evidenced by GLS, and HFrEF can have diastolic dysfunction, which we commonly see in our day-to-day practice.
Absolutely. There have been kind of very conflicting studies done over the HFpEF, the use of the MRAs. One of the study, the top cat says that this is proven non-inferior. The use of the MRA is non-inferior, as opposed to Aldo HF says, well, absolutely no use. So I was kind of very much confused that, but now with this, we have got some clarity that yes, it can be used with the patient with the OSA. That's fantastic. Thank you.
as there are no more questions, I like to have suggestions from all of you, from the delegates as well as the faculty, how to improve this program. I think the attendance was very good. We have 150 login, and I'm sure in times to come we have to conduct such meetings because of COVID. So you will have more such meetings, and you can pass on your suggestions or whatever, how we can improve this meeting in future.
Sir,
and I'm very thankful to all the delegates, the chairpersons, the faculty. They've done an extremely job. They were very attentive, very punctual, and they have fulfilled our expectations. And we are very proud of all the faculties and the chairperson.
Sir, thank you very
Yes,
much.
ma'am.
Hearty congratulations.
Your effort.
But my only problem is, how will you give the jalebi and rabdi and group photograph, sir?
Likewise, I also have one problem, Dr. Manoria.
I will put it into your mouth from air. Just open it, I will put it in the jalebi.
That's I'm missing, absolutely. And another question, since my childhood days, when I was your medical student in medical college, you always wake me up early morning, 6 o'clock. Today also you wake me up at 6 o'clock in the morning. You can imagine how difficult it is. I'm opening my eyes. Those days I also was falling asleep, and today also I was the same.
Early to rise, early to bed. Early to bed, early to rise makes you perfect, healthy, wealthy, and wise.
I'll never forget Dr. Manoria for this.
Wonderful presentations by each one of you, and a special thanks to Dr. PC Manoria and his team, who have done a great job for arranging this webinar.
Group photo, sir.
Thanks to each one of you.
Next time we'll arrange. See, we are having World Congress on February, but I doubt it will be possible to conduct a live meeting. We are postponing it, and to April or May, still the situation does not improve. We will have similar meeting for the Second World Congress. We don't know how.
Yeah, but we will postpone it to later days. Please don't cancel it. I'm really looking forward for it.
I am also very keen to have a live meeting, but I don't know what will be the state of affairs of COVID in Mumbai.
I think we are probably at the tail end of the problem.
It will not be possible within 6 months. I think within 6 months it will not be possible at the moment.
Difficult.
Only
we are kind of very optimistic. It looks like we are at the tail end of the problem now, and hopefully within the next 2-3 months we will be having a vaccine that get going. Basically, we issued orders for 39 million vaccination and all not. So hopefully, at least from the Western world side, we should have some winning over the situation.
Want to meet all of you in person and have jalebi.
Yeah, especially for rabdi and jalebi. I can't agree with Dr. Vijayalakshmi.
Helpless at the moment.
And the group photo.
Oh, that's it.
Yes. Yes. Sure. Next time meeting will somehow arrange a group photo on web meeting also. We'll ask.
Yeah, we should do that actually.
Could have been taken, with all of us.
I'll ask Dr. Chandrasekhar to have some technology for that.
Well, I have got the screenshot with all of you now. I probably will send you everybody in the next few seconds or so. I got the screenshot for.
So I think time has
So
come to
hopefully
say
we
bye-bye.
can post this picture somehow. So have your number.
Excellent organization, sir. Thank you very much. Thank you very much from our end. Excellent topic.
Sir, thank you very much. Namaskar.
We also thank you, sir.
Thank you
for inviting us.
Manoria. Congratulations for wonderful conference. Yeah, I agree.
Dr. Brother, you want to say
Thank you, sir.
something?
Yeah, we can have the virtual photograph with the technology, sir. That should not be an issue.
Okay. Dr. Gulati.
Everything was fine.
Newer technology application in cardiology.
Yeah.
If possible.
Dr. Gulati.
Thank you, Dr. Manoria. Excellent conference.
Thank
Very
you.
nice presentations.
Thank you, Padmashri.
Everyone. Yes, take care. Bye now.
So bye-bye to everybody. Thank you very
Thank
much.
you, sir. Thank you.
Bye-bye. Bye-bye.
Bye-bye.
Thank you all. It was great. Absolutely great.
Right.
Yeah, agree with you.
Thank you very much.
Yeah.
And bye-bye.
Thank you.
Thank you, sir. Thank you, sir.
Okay.